This meeting to order. Appreciate everyone being here today. Roll call, please.
Senator Alvarado.
Present remotely.
Thank you. Senator Carroll.
Present remotely from my district.
Thank you. Senator Higdon. Senator McGarvey.
Present remotely.
Representative Gooch. Thank you. Representative Gibbons-Prunty.
Present remotely in my district.
Thank you. Representative Sheldon.
Present in the room.
Representative Wilner.
Present remotely.
Thank you. Senator Meredith.
Present in the room.
Representative Elliott.
I'm here in the room.
Thank you.
Thank you. Obviously, we do have a quorum. Next order of business is approval of minutes. Is there a motion?
Motion. Second.
Motion and a second. All those in favor say aye.
Aye.
Anyone opposed? Motion passes. Thank you. Also, we've got a big agenda today and a lot of heavy lifting here. I appreciate everyone being in attendance. Just to remind those who are on Zoom, folks, if you would, to mute your mics. And if you have a question, I think we'll hold them to the end of each presentation so that we can keep this thing flowing, because I want to make sure we stay on time. And for those who are presenting today, be sure that you turn your mics on at the table, no matter pushing the button. Let me give you a little preamble of this. Is what formulated this agenda is I asked a question about the efficiency, the efficacy of our substance abuse programs, and could not find anybody who really could give me an answer. So I think it's one of those things where it's everybody's responsibility becomes nobody's responsibility. So I'm just trying to wrap my arms around how good job we're doing, how much money we're doing, what kind of return on investment we're getting. So again, it's not to try to chastise people or condemn people or criticize people. It's just an open, honest communication as to what kind of job we're doing, because obviously this is a big need, a big area that we need to address. But and it ties in a lot of different elements of our managed care program for Medicare. But with that, let's jump right into the agenda. First is an update on prior authorization requirements, provider networks adequacy, and the necessity of substance use disorder services covered by MCOs. Again, that in itself is a big agenda item, so I appreciate everyone being here. If you would, identify yourself for the record, and we will proceed.
Thank you, Mr. Chairman. My name is Tom Stevens. I'm the Executive Director of the Kentucky Association of Health Plans. We appreciate the opportunity to be here today and present. I'm going to turn things over to our first presenter, Dr. Sandra Guerra. Dr. Guerra is the Chief Medical Officer for WellCare.
Hello, Chairman. Hello, everyone. Thank you so much for the opportunity to speak to you. My name is Dr. Sandra Guerra. I am the Chief Medical Officer for WellCare of Kentucky, and I've been in this role since January of this year. I've been in managed care for approximately 10 years now, and I am very pleased to be able to speak to you a little bit about what the value of managed care is as we launch into this very important conversation of all the different services that are offered within managed care. So some of the things that we can definitely speak to regarding the value of managed care is, first and foremost, is ensuring that quality of care is being provided to all the members throughout our Commonwealth. And so collectively, that is something that we're focused on. We also focus on utilization management, not because of wanting to provide a barrier for care, but ensuring care that is being provided is actually medically necessary, because providing health care services, especially when we think about procedures or other things, can actually be harmful to a patient if done when it's not medically necessary. So part of the role of a managed care organization is to try and protect members from getting unnecessary medical care. We also believe in making sure that members are receiving care at the right level of care to avoid some things that, unfortunately, we have seen happen before historically, and that is institutionalization, infections that are garnered while in a facility, errors in healthcare medications and procedures. So it is part of our responsibility to make sure that we are managing utilization over and underutilization. We also have a responsibility to make sure that providers who are taking care of Medicaid members in the Commonwealth are credentialed. And that credentialing process is actually a deep look into the history of a provider of all different specialty types and making sure that they have provided safe care in the past. And if we find that there is a problem with a provider, it's also our responsibility to remove them from the network in order to protect members. We partner with other organizations to address member needs, including social determinants of health, which I'm sure many of you have heard a lot about. And we engage with professional organizations to address concerns and problem solve with them. We guide healthcare practices with standards of care and making sure that people stay abreast of what those are. And we expect providers to attend to the healthcare needs of members in an equitable setting, all languages and culturally sensitive ways that our members deserve.
Mr. Chairman, representatives of the Oversight Committee, I appreciate your time today. My name is Jeb Duke. I'm the Health Plan Leader for Humana Health Horizons. I'm also the Chairman of the Kentucky Association of Health Plans. Mr. Chairman, one of the other questions you've asked us to kind of dive into is what's the value of managed care? And as we're reaching our 10-year anniversary, what is the Commonwealth received with moving forward with a broad-based managed care program? Now, what I would answer and tell you is that you have strong contracts that are providing value to the healthcare sector. A broad base of citizens in Kentucky, 86%, believe that a sustainable Medicaid program is critical to our success. And 71% of Kentuckians believe that positively have a positive opinion about Medicaid today. We represent over 1.5 million Kentuckians from a healthcare coverage perspective. That's 1 out of 3 Kentuckians. That's 1 out of 2 births. Our impact is broad. What I would tell you is the contracts that you have executed are some of the most aggressive contracts in the United States from a contracting perspective. If you think about how we're structured, we're required to pay 90% of all of our premiums for healthcare services. We have a 9% allowable for operational costs, for provider supports, and for our quality programs. But probably most important to the Commonwealth is, as we think about the portion for potential profitability, that's 1 penny out of every dollar that's provided to our healthcare MCOs is what is potential for profitability. If healthcare costs rise throughout the year, the healthcare MCOs are required to cover those costs. We're accepting the risk for potential as costs rise. If costs decrease and utilization decreases throughout the year, this is really the largest component of risk management. Those dollars are required to be returned to the Commonwealth. What we've seen, if we do a look back over the last 10 years, there's been years where health plans have been able to achieve their 1% potential for profit, but there's also been years that we've returned value in dollars back to the state. This is important that it provides certainty as you think about budgeting for healthcare costs within Medicaid. A recent study looking back as we transitioned for fee-for-service to managed care evaluated states that remained within fee-for-service, and then they evaluated healthcare trends within Kentucky over that 10-year period. And what that study found is that today, from a state budgetary perspective, managed care saves the state, only looking at non-expansion members, $300 to $400 million a year. But what we also see is that we're making improvements on health outcomes and quality. We have more Kentuckians getting immunizations. We have more citizens getting cervical cancer screenings. We have a significant rise over the last 4 years of the number of children getting well child visits. We have women who are getting prenatal care timely. We have members who are receiving care when they need it. One of the most important points, if you look 10 years back and you transition from fee-for-service to managed care, what we've seen is a 49% reduction in the number of avoidable hospitalizations within the state. We've also seen a 41% reduction of the number of members who are discharged from a hospital being readmitted to that same hospital. And most importantly to the healthcare plans, what we have found is that the members that we serve value the health care that we're providing them. If you ask our members if they had to rank their health plans on a scale of 1 to 10, 81% of our members would rank their health plan as an 8, a 9, and 10. We're going to transition to specific topics about behavioral health, but Chairman, I did want to be responsive to some of the questions that you've raised in some of the prior meetings. Next, we have Liz Stearman. She's the Behavioral Director for Humana Healthy Horizons.
Liz, you need to hit the button on your.
Thank you. Hi. Thank you, Mr. Chairman and committee, for having us out to speak today. My name is Liz Stearman, and I am the Director for Behavioral Health Services with Humana's Healthy Horizons and Kentucky Managed Care Plan. So I'm here to address some of the very specific concerns that have been brought up around behavioral health, both mental health and substance use disorder treatment. So all of our managed care organizations in the state really rely on the department and the contract that we have with them to guide the services that will be covered, delivered, and available to our Medicaid members in Kentucky. That benefit structure is really driven by the state plan that the Department of Medicaid has approved and sent through to the federal government through CMS. Once CMS approves that state plan and states these are all the services that you are able to use your Medicaid dollars for your enrollees, they pass that on to us through contracting. So the MCOs across the board, regardless of however many there are in the state, are required through that contract to make available those services to all of their members. We have to ensure that we cover those benefits and that our members have access to receive those services wherever they live in the state. Our state plan currently for behavioral health has a full array of coverage for mental health and substance use disorder treatment. And that array is comprehensive from preventative services, when we're assessing and trying to determine what the needs of our members are, all the way up to the highest levels of care, which include inpatient, acute care, and residential services. All right. So next, we're going to talk a little bit about prior authorization, and Dr. Guerra talked about that a little bit. And it is a common misconception that insurers or managed care organizations place services on a prior authorization requirement as a cost containment mechanism. We're here to tell you that there are many primary drivers, and cost containment is not always one of those. Our number one priority, as she stated earlier, is our member safety and the appropriateness of care. We know that in the state we have limited resources, limited providers, and we have to ensure managing our membership that the right folks get access to the right levels of care. We have to make sure that their health outcomes are of primary concern not only to us but also the providers that they are seeing in their communities. In addition, it allows us to monitor those services for potential overutilization, which is not only harmful to our members, but also not a good use of the limited resources that we have here in our state. And then maybe most importantly, and not always known, is that utilization management function for authorizing services is often our first trigger to engage and activate around our members with the highest needs. The managed care organizations have a full array of care management services that we can offer. So when we get that notification that we've got a member walking in the door somewhere with a pretty significant or acute need, that allows us to activate our care management teams around that individual. That may mean that we are bringing social workers and nurses into the picture to assist either with the provider or with the member's families and caregivers. We have lots of folks working on social determinants of health alongside just those sort of medical practices. So we can bring in a housing coordinator, we can bring in our employment coaches, we can work on the background to really eliminate some of those barriers that we know our members are experiencing on their journey to healthy outcomes. Without having that trigger mechanism of alerting us at the moment and as real time as possible that we have a member in crisis or in need of that level of care, we're not able to activate all of those services and bring them forth. There have been some concerns around parity. I know that have been expressed, parity between mental health and behavioral health services alongside our physical health and medical care. And every MCO is required to do mental health parity analysis on regular and recurring basis under the oversight of the department to ensure that we have equal and equitable access to both mental health, substance use disorder treatment, and all of the sort of traditional medical benefit as well. Another thing that I want to make sure everyone is very aware of, we don't put prior authorization on a lot of services that we know that our members need. Most importantly, it's very costly to enact a prior authorization process, not only the administrative burden on the provider side, but also from the managed care perspective. It does take a lot of resources to conduct reviews, be sure that we are thorough and accurate, and that we are really focused on member safety. So we choose only to put that authorization requirement on the services where we know that we can impact the outcomes for our members. So the majority of behavioral health services aren't actually required to have an authorization. When you talk about preventative care, especially crisis care, if somebody has shown up and they are in crisis at that moment, a prior authorization is often not required, and we're going to be doing that once the member is safe and secure. Okay. A few of those services we've listed here for you guys to look at too. All right. The next thing we wanted to sort of discuss and touch on is the impact that we have seen in our member and population over the last many months. We have had no prior authorization on any behavioral health or substance use disorder treatment services since April of 2020 due to the COVID-19 state of emergency. Obviously, that does decrease the administrative burden on the front end for some services that our members need to access. However, we are really noticing a lot of very adverse impacts to Kentuckians that may not have been anticipated. Some of those impacts that we have seen here, it really limits our ability to conduct all those functions that we just talked about were the benefit of the prior authorization. Once we know that we have a member in a setting where they are either inpatient or residential, part of our function as a managed care organization is to work collaboratively with the provider and the member and the caregiver around discharge planning and preventing an escalation of treatment needs. So we are activating those care management teams, and we are working actively with facilities around discharge planning. What is preventing our members from safely returning to their home and to their community? And what can we bring as a managed care organization to bear to remove those barriers and ensure that we are preventing any readmissions wherever possible? A lot of times that is coordinating aftercare services, arranging for transportation, all of those types of things that we currently are not able to activate around if we're not aware that the member is there in some sort of real-time capacity. It also limits our ability to ensure the quality of care that is being delivered. Without access or notification to see any kind of treatment plans, clinical presentation, documentation from the provider, we are not able to ensure that that level of care is actually truly appropriate for the person that they are treating. And while the removal of the authorization is intended to increase access, what we're seeing is a lot of times it's actually decreasing access for individuals, because what we see is we have folks that are being treated at the highest levels of care within our substance use disorder and mental health sort of array. We have a bottleneck at that acute and inpatient and residential level of care where we have folks staying much longer than historically. Our average length of stay is increasing across MCOs between 12 and 16% for mental health and substance use disorder treatment. However, we see the number of individuals that are being treated actually going down. Our admits per 1,000 member are decreasing by about 16% from previous years to post April 2020. So what we know
Excuse me, but is that a fair number, given that a lot of services are seeing decline because of COVID? People are just afraid to access the service. I mean, may not have anything to do with this particular.
You're absolutely right. I definitely see your point. Our problem is that if we've got these folks already in those beds, they are turning people away that are coming for treatment. It's not that these folks are sitting at home so they have not been able to get in. It's more that when they come to access services, that those facilities may remain full because they have folks staying that may be appropriate to move to that next level of care. And what we see in our utilization and claims information is that the medical cost is driven, I think it's on here, is being driven by Pre-existing members, so members who have historically received these services prior to the COVID pandemic, are actually staying longer, and they are not accessing the lower levels of care at the same rate that they were previously. So we're staying up in our residential levels of care, and we're not seeing the same type of spend as they move down.
Well, does that defeat your argument that MCOs are doing a good job in improving the quality of care in Kentucky, where obviously they haven't been able to access care before? It's because of this particular situation that they're now accessing care and getting other problems taken care of. I think what we need to know specifically with this prior authorization, has it cost more?
Yes.
And you're saying that it has?
Yes.
Has not improved the quality of the service?
No. Because we're seeing readmission rates stay the same. We're seeing the average length of care also increase. So the argument that maybe if folks are staying longer, that maybe it will prevent readmission, or it will allow them to remain stable in a lower level of care, we're not seeing that either. We're seeing the same members churning through those higher levels of care and having the same readmission rates that we saw before. In those lower levels of care, like access to, let's say, like individual therapy, intensive outpatient, things that are not at the highest, most acute level of care, we see fairly steady trends. The relaxing of the telehealth restrictions, we think, is actually one thing that has really helped sort of even that balance out. You're right, there's a lot of folks that don't feel comfortable going out, and they're not going to just show up in an office and have an intake at the same rate that they were before. But that relaxing of the telehealth requirements that's been able to go into place, and the fast action of our provider community to really adopt telehealth practices, has helped our lower level outpatient behavioral health trends stay very, very steady. We would sort of expect to see a dip in those services because people are staying home. The kids aren't in school. They're not getting those school-based services. At least previously. Now most of them are back in. We actually have seen that stay extremely steady across from both prior to the COVID state of emergency to today. So they're still accessing those lower level services. Where we see the cost increasing, that driver there is in those very, very high and acute levels of care.
Well, could another reason for that being that we've added 250,000 people to the Medicaid rolls during this COVID crisis. And again, people who didn't previously have access to care now have access to care.
Yes. And, that's something that we absolutely have looked at. So we actually look at who is the member population that's included in those main drivers, right? So we can identify, here's where the big increase is happening. Let's look at the member level. Who are these individuals? And what we've seen across MCOs in our research is that these are individuals who were accessing that level of care prior to this. I think everyone is very well aware that we have sort of a shadow pandemic in the behavioral health and substance use disorder world because of the isolation, depression, grief, everything that's happening, anxiety related to the pandemic. So that's where we see those new folks coming in. They're getting those low-level therapeutic services and interventions. They might be being treated by a therapist. They might be going to a group therapy session. We do not see that new population of people that had not previously accessed services before entering into those highest levels of care. They are our new entrants, and they are in those preventative care and outpatient services. That's not where we're seeing our trend driver.
Well, cutting to the chase here, obviously we've got to make some decision by the first of the year as to whether we support continuation of elimination of prior authorization or go back to our old method. So
yeah, and we have
from
some
y'all's perspective, what's your recommendation?
Sure. Well, thank you. That's the next slide here. So we did put together some recommendations. We recognize, like we said, it is administratively difficult and costly to administer prior authorization programs, and we don't want to go, just flip a switch and expect everybody to go back, like you said, in January to the state that we were necessarily in before. We've been in our current state for some time, and we're going to have to work toward sort of titrating up and really evaluating where's the opportunity to improve the outcomes for our members. So we have a few recommendations that we've put together here. We do recommend reinstating authorization requirements related to behavioral health, but there are some strategies to do that. It does not have to be a light switch. Similar to what's happening on the physical health and medical side of things, we could decide to really focus at the service and treatment level of what do we want to do first, and what's the low-hanging fruit that will allow our members and providers to still access and provide quality care, but we can start to address some of those negative impacts and outcomes that we're seeing. So we could be staggering maybe based on inpatient or outpatient authorizations, maybe only returning an authorization requirement to very choice and specific services. We could also be looking at, at really where do we see the most concerning trends. We're seeing a lot of children under the age of 18 who are staying in institutional settings for a much longer period of time. It might make sense to look at some of those very targeted services where we can show through our data that it's having that negative impact on that population. Additionally, we can also look at authorization on a concurrent treatment basis. There's an opportunity to look at, maybe we don't look at it prior to the service starting, but at a certain point in treatment, let's start that review and start that collaboration so that we can really actively be working toward a safe and timely discharge to improve the access for the folks trying to come in and access those services. And then another thing that we can also consider is setting up advisory committees between managed care as well as, with an oversight of the department to really identify, hey, let's start taking a strategic approach based on data. What are we seeing in the data that we report around these services? And let's try and make sure that we can improve the outcomes where we see the most disparate changes.
Well, as a segue into the next part of this discussion, one of the challenges, particularly for the district that I represent, is being able to find healthcare providers to provide the services you need.
Absolutely.
And when they can, particularly on a primary care basis, it becomes much more critical. And when they finally have to access it, it's an emergency situation usually, which is very expensive care. Mm-hmm. And I know as part of the RFP that each of you have to present to the cabinet, that network adequacy is supposed to be an important part of that. But I have a lot of anecdotal experiences where people say, I can't find a provider. Mm-hmm. I remember one in particular was with dental services. It wasn't in my district, it wasn't in the state. And this guy needed a dentist almost immediately. And nobody would take him in that area because he had Medicaid. Mm-hmm. So where's the network adequacy specific to that?
I'm going to pass it on to Leon here. All right. Thank you.
That's great. So, Senator Meredith and members of the chairman or members of the committee, I'm Leon Lamoureux. I'm with Anthem Blue Cross Blue Shield as their market president here in Medicaid. Thank you for the opportunity to address some of the network adequacy concerns. You had mentioned, Senator Meredith, about the energy that goes into the RFP responses. There is ongoing energy. In fact, we have quarterly reports that we have to submit to the state about continued network adequacy. There are compulsory requirements that we have, urban time and distance requirements. There are also rural time and distance requirements for about, I was trying to count before I came up here, I think it's 39 different specialties that we have to report on in the reports that we submit to the state. And these look at everything from the network adequacy, the times that we have to refer out in areas where we might need to get a single case agreement in place. You mentioned an experience of a person in dental work, for instance. We've seen things with traumatic brain injuries where we may not be able to find a resource in state or something, and we have to do single case agreements nearby. We have to report on those single case agreements. We also have a quarterly requirement where all MCOs have to submit reports. And you can see I just pulled two examples from a 47-page report that we have to produce quarterly for the state to be able to demonstrate that time and distance requirement. Now, time and distance is only part of the access variable. Availability is also part of that access variable. And I'm sure you can understand, having been a former administrator of a hospital, there are different reimbursement levels that take place, whether it is a commercial member, a Medicare member, or a Medicaid member. And we need to be able to address some of those and provide extra services at times for those that are really, really hard to address. The time and distance requirements, we also have to supply information on a quarterly basis about survey work that we do within our networks to make sure that people are able to get the appointments within the contracted times. And so I wish we would have 100% access at the very time that the person needs it. In our most recent survey, for instance, speaking of Anthem, not as the KAHP, 91% of the time our primary care had access within the time frames. But that means that there was 9% of the time when they did not. And so it's always something that we're working to try and improve. And we do that through a variety of ways, whether it be augmenting those services with value-based payment arrangements, with extra access benefits, being able to provide value-added benefits to the member for travel and some of these other types of things that we as managed care do. We also have a layer of oversight that's not part of DMS, but it's part of our NCQA accreditation. So those of us, all of us here that work within the state are NCQA accredited. That is the National Quality Accrediting Agency that overviews managed care. And we have reports very similar to the reports that we have to do here to be able to document those time and distance and access requirements. I will tell you that for Anthem, in our last report, we only had 1.6% of the medical practices that were closed to new members. And so there is still opportunity, I think, to move that needle. But there are times when access is a challenge. And COVID in particular has even created greater access challenges because of providers no longer able to be open or have support staff or some of the other challenges that we face.
Well, excuse me, but I hear that and understand that. Mm-hmm. But I've been told since I've been in the Senate, since 2017 was my first session, that rural health care is important to all the MCOs.
Indeed.
But I've never seen anyone step up to help improve that situation. And let me ask you a very specific question.
Mm-hmm.
Why would any doctor choose to go to rural community when you know that you're going to be heavily dependent on Medicare and Medicaid, which doesn't pay the cost of care, going to have more challenging patients, going to have more non-compliant patients? They're going to be making 25 to 30% less than their urban counterparts. Why would they go to a rural community?
Because they want to serve in that community.
Well, those are few and far between this day and time, particularly when you got $250,000 in school debt that you've got to pay.
Right.
And I've got a son that's in a very situation. He decided to come back home. Mm-hmm. And I didn't encourage him or discourage him. But I got a question is, why would you want to do that?
Yeah.
But that doesn't address the problem. Very few people want to do it because usually if they come because they have an emotional attachment like my son has, right, or you have a passion for that rural community. But that's a very rare situation.
Right. I had a chance, Senator, to meet 8 of those individuals 2 weeks ago when Anthem went to Eastern Kentucky University to do a scholarship program. And the return for those scholarships is that each of those 8 nurse practitioners will remain in Eastern and rural Kentucky to practice for at least 3 years. So that is something. You wanted to know specifically
that's
what are we doing.
That's an age-old incentive even for physicians.
Right.
Again, my 40 years in healthcare can tell you that's not effective for a long-term solution. They're there for a couple of years and they move out, but you're not addressing the fundamental problem that there's a critical healthcare shortage in rural Kentucky,
right,
and it's causing the health to be worse, costing the state more. Why aren't we investing more in rural Kentucky rather than less to help address those problems? Why, from a business model, does that make sense to pay rural providers more than what we pay them?
It may very well. I think those are things we can work together on, both with this body as well as DMS and the MCOs.
Well, that's what I've asked for 5 years. And again, people say, rural health care is important to us, but nobody has ever delivered a plan to do it. And it just doesn't make economic sense to me because, again, they're not coming to rural Kentucky. You mentioned nurse practitioners. They certainly feel part of the void, but they're not filling all of it.
Right.
And it's not just affecting physicians. It's every healthcare professional. We see the same thing with pharmacy right now. We battled for the last 4 years on equitable payments for independent pharmacists in rural communities. We've had to fight that battle. We shouldn't have had to fight that battle. I know in other states, such as Connecticut, which is a model I'm very interested in, ASO model, that they actually had 2 different pay schedules for pharmacists. For independent pharmacists, it's higher than the big box stores. And I think that's what we need. What we're asking for is a little bit of equitable treatment here. People tell me we treat you equal, the pay scales are equal, the charges are equal, but it's not equitable when you got 75% of your patient volume that doesn't pay the full cost. They're carrying a burden that they shouldn't have to carry. So I want to know, what are we doing for rural health care to make it an equitable system? Presently, it's not.
I can't argue with your point, Senator.
Well, in this particular issue,
yeah.
I talked about this guy trying to get dental service. You know, and your surveys are fine until you're that patient has to deal with that problem. He did everything he was supposed to do. When he couldn't find a local dentist, he called the helpline. Nobody could help him because there's nothing there. That's not network adequacy. I got an email today from a licensed psychologist that does community support services for a 17-county area, and she just recently had an audit by one of the MCOs, denied 100% of the services that she had offered, even though 2 other MCOs said, you're fine. Now, she's in a position where I can't provide a service for free, and these are vitally needed services for that community, but we don't work with these people. We make it more difficult. I appreciate your glowing, or Mr. Duke, your glowing commercial for the MCOs, but that just hasn't been my experience. I think we're paying a premium for managed care. We're going to hear later from our Medicaid department that their expense portion, I think, is 1.75% to run the Medicaid program. Your all's is 10% in addition to that. I think it's a little bit more than that. So we're running probably 13, 14% administrative expense for the Medicaid program and not getting the results that we deserve. In the 10 years we've had Medicare, we've only moved the bubble just a little bit. 10 years ago, we were 47th in health outcomes in the United States. Today, we're 44th. And I don't think it's because you guys have done a good job. I think it's because we provide more access to care because we've had expanded Medicaid. But again, it doesn't do any good to have coverage if you don't have access to care. And that's what's happening in rural Kentucky. You're killing the system. If you all have heard the testimony we have over the last 3 or 4 months, Budget Review for Human Services, every healthcare provider has come to us not just asking for help, financial assistance, they're begging for financial assistance. We have a crisis brewing like we've never seen before. And this whole system is going to collapse if we don't do something, but I don't see anybody doing anything. And I think, things like network adequacy, it may sound good in theory, but practical application, apparently it just doesn't work. It's not there. It reminds me of that adage about, don't believe in averages. If you did, then nobody would drown in the Rio Grande River because on the average, it's like 3 inches deep. But you can. And that's the problem with your numbers is it doesn't hit home to specific instances. It means nothing. I've told this story 100 times to my colleagues, and folks, I'm sorry I'm going to have to share it with you again, but here's the essence of the problem. When I was in the business, my hospital was one of the last rural hospitals to offer obstetrical services. And like any good hospital CEO, I realized we're subsidizing this heavily because it's heavily Medicaid. You're not paying the full cost. We can't continue to afford to do this. Had to ask myself that 1,000 times. But we had a young mother, 18-year-old, who delivered a preemie in my hospital. They had transferred to Louisville, which you would expect. Nurse assistant goes to her room, finds her mother crying. She's trying to assure her, everything's going to be all right. Don't worry, your baby's in good shape. She says, that's not what I'm crying about. I'm crying because I don't have the gasoline money to get to Louisville, 70 miles. So a bulb goes off in my mind. If you don't have the money to drive to Louisville to see your critically ill baby, you're sure not going to have the money for for prenatal care and postpartum care. Mm-hmm. That's the problem in rural Kentucky is we don't have the financial resources to access services that you folks say that you can offer. It's just not there. And I don't understand why we continue to have such a sick population in Kentucky and we're not working actively to improve the health of our population. If we did, we all benefit from that. But we don't. Only one profiting from this thing is you guys. Sorry.
Senator Merritt, what I tell you is, from a health plan perspective, not all health plans are profitable in Kentucky, and they haven't been. It's even true during the pandemic. I would say from an access point, one thing that managed care does do that fee-for-service can't, when we do have troubles with adequacy, in many cases we pay above the fee schedule. So some rural providers where there's a lack of an access point, we have the ability to increase fee schedules. From a perspective of looking at fee-for-service in Kentucky versus managed care from an administrative cost, first I would encourage you to look apples to apples from a premium perspective. If you look at fee-for-service Medicaid, it's mostly LTSS services and really high acuity members, specifically children and people on waivers programs. So if you look at it from a cost perspective, it's very high premium. So if you think about the cost as a percentage, it's not an apples to apples comparison. In regards to the Connecticut model, I do think we need to kind of explore and make sure we're also comparing those apples to apples. If you look at Connecticut costs per member per month, comparatively Kentucky's, Connecticut is 24% larger than Kentucky. And also just making sure that the acuity level and the level of needs of members in Kentucky, which is a state where poverty is an issue, where obesity is an issue, where diabetes is an issue, we're a leader in tobacco utilization. We're trying to address those needs within the scope of the dollars that are provided through managed care. I think policy decisions and discussions around fee schedules, managed care would be happy to come to the table and talk about the needs of our providers, but I think we have to do that in partnership with the administration as well as with the legislature to ensure we're achieving the outcomes that we're seeking to do through the policy changes.
Well, I'm all for comparing apples to apples, but I think that the apples that I look at maybe different ones than you do. I do look at Connecticut, the third healthiest state in the United States. Their expense ratio for a Medicaid program is 3%. A decade ago it was 5%, but they've been able to get it down 3%. We're at, as I said, I think between 12 and 15%, and obviously we're not getting the outcomes I think that we should. We're not moving the needle at all. All we're doing is spinning our wheels, and it's costing our taxpayers, it's costing the employers of Kentucky because we're not improving the health of the population. And I understand this multifactoid, but particularly access to care and network adequacy. And I think if you guys are going to be measured by that, then there should be a strong, sustainable network of providers. And what I'm seeing from these anecdotal experiences is that's not the case. Calling the 1-800 number to me is not the same as being able to access a healthcare provider. And that's what we're dealing with. And it goes back to this original question about, how are we doing with the substance abuse disorder? Specifically, let me read for you. Kentucky Revised Statute 222.475, Cabinet shall annually submit to the governor in the General Assembly a treatment center evaluation report. The report shall include but not be limited to the following, in inventory of all this stuff, but the fact is, we've never seen that report. How many millions are we spending on substance abuse to try to address this problem, and are we getting results? Nobody can tell me. Can you folks tell me? And why don't we have that report? Do you all have that report? I think it's part of your all's responsibility. These providers that you're contracting with, they're supposed to give you reports. How come we don't have those reports? Why can't anybody tell me whether we're being effective with our substance abuse programs or not?
Mr. Chairman, absolutely, we can take that back and provide you the detail of what incremental report we are doing for substance abuse and what we do on a recurring basis for reporting. We do submit 70 reports on a recurring basis to the Department of Medicaid Services to ensure we're meeting our contractual obligations. I'll make sure we carve out what's related to behavioral health and provide you a specific response to that so that I'm accurate in my response.
Or do you know of any reason why the Cabinet can't provide us that report?
I don't want to speak for the Cabinet, Mr. Chairman. I'm not sure of the details.
Okay. just other maybe peripheral comments here, but when we talk about reducing administrative cost, two of the initiatives that we've been involved in heavily over the last couple of years, one is single source credentialing, which to my knowledge we're still not there. And I appreciate Dr. Guerra's statement about, it's an important part of ensuring you got a quality network. You don't want bad providers in, but it's never made sense to me from an administrative standpoint why we have to credential 6 times for one physician. That's not cost effective by any means. And if you're looking at reducing your own cost, wouldn't it make sense to just do it one time and share that information with everybody else? But we don't do that. We never have. Same with our single source PBM that we've been working on. It's been a struggle. We know there's savings there, substantial savings to the Commonwealth, but we're not moving forward at the speed I think we need to be moving forward. Now, I know I've got a reputation that, I don't like MCOs. I don't want an MCO contract. And I think that's a mischaracterization. I'm willing to work for you folks, but so far all I've gotten is lip service. Again, when you tell me that rural health care is important to you, no, it's not. Haven't done a single thing in 5 years to improve the health care delivery system for rural Kentucky. You're not recognizing critical needs of these communities. But I don't think our legislator has as well. Just last year we had to deal with giving $35 million to the University of Louisville to buy a Jewish hospital. But when I asked for help for Our Lady of Benton Hospital in Russell County, not even in my district, a small community that has 1,000 employees, we do nothing for them. Nothing. Where's the parity in the system there? Where's the equity in the system? As I said, there are a lot of discussion about equity in society today. I think that's a real issue, not just from a racial perspective, but urban versus rural. And I don't think that rural communities have been treated equitably and aren't today. And it goes back to that basic question I answered for you is, why would anybody choose to go to a rural community other than it's a mission for them or they got a passion for it? And if we're taking advantage of that, we're taking advantage of those people. That's not fair. And if our most critical healthcare problems are in rural Kentucky, or aren't we making an investment to improve that? And by that, we lift the boat for everybody, but we don't. Anybody got anything else? Feel free, Sheldon.
Mr. Chairman, please, you can't, I'm ready to go whenever you are, so let me know when you're ready for me.
Right after Sheldon, we'll let you go, Dr. Alvarado.
Okay, and thank you very much for being here today. It's obvious we have an MCO system across this country that in various states, depending on what you're looking at, some of them are running with 15, 20 MCOs, some of them are running with just a few, some of them don't even use MCOs. Okay, so, we're at a crossroads here in Kentucky. We've talked till we're blue in the face. We don't know that the finger doesn't need to be pointed just at you. It's a healthcare system, very complex. But a lot of what we're trying to do in Medicaid, and particularly behavioral health, there's got to be some solutions. And I'd like for you all to try to come up with some solutions. I think that we could start maybe with this whole, we only make a penny on the dollar kind of thing. I think I was involved in a fairly complicated piece of legislation a couple of years ago, and we were working very closely with the cabinet, and in the middle of that discussion, and we ran into a situation where we couldn't identify about $7 or $8 million. It looked to us like probably shouldn't have, that it was owed to us, and so we inquired from the MCO, and lo and behold, and I'm not calling anybody out in particular, but lo and behold, it was found that $8 million had been shifted into another revenue area, and it shouldn't have been, and so that $8 million was refunded. Then when we asked for all the money that they had done that prior years, apparently in the contract it only allowed us to go back 12 months. So I don't know how many millions of dollars was taken from the state, but that's been a couple, 2 or 3 years ago. So I want Part of the solution could be some more accountability on how that 90 MLR ratio is used and planned. And I would say after that, more than likely, it's probably gotten a lot better. But anyway, I want to bring that as part of maybe a solution going forward. And there's so many things you guys covered. I want to try to maybe hit one or two other things. One, Senator Meredith mentioned audits, and I know you mentioned it as well. And thank you for those are things that you do to try to make yourself better, right? I mean, it's the whole idea. But I'm concerned that there's probably requirements. I don't want to put word in your mouth about so many audits and you got to have so much done. So we eliminated the audit process, I think, through a lot of the pandemic. Y'all can correct me if I'm wrong, but I think there's something came up where we allowed everybody to just kind of wave those off for a while because all the providers were just undercover trying to take care of things. But since, and they've come back, I have gotten a zillion emails from providers saying, I am getting overrun with audits. One audit after another, and after another. These poor providers are absolutely overrun with audits, and their only assumption is that, well, they got so far behind when they were told they didn't have to do them that they're getting caught up. And who is that fair to? Why are we doing that to our providers? So I want to throw that out. I got a list of things a mile long here that but please write it down and think about that and think about what's going on here. We need to do audits, but that's just not something we need to be doing. And maybe let's talk about maybe the step level type therapy that the thought process that went into Connecticut's that we may go to from the pharmacy side of things a little bit like that maybe down the road where we're taking a look at fee schedules and we're making them appropriate for a particular area and I don't know that that's not a bad solution for you guys to get together on and come up, because you're probably basing your fee schedule on Medicare allowables to some extent. I don't know. There's probably a lot larger, complicated process. I'm just saying, for the most part, that's what you see as a healthcare provider, right? So maybe there could be some getting together of minds about, okay, in rural Kentucky, it costs a lot more to provide health care, and it's tough to get access there. Maybe there needs to be a difference in the fee schedule there. So again, some of these are fairly reasonable solutions, and if we could just get a report back on some of these ideas, now they may fall on their face once you get to looking at them, but we would love to hear ideas like that coming at us rather than us having to throw them back at you. I'm sure you've gotten a lot of these same phone calls we're getting. I just would like to hear more solutions. And rather than because I know Senator Alvarado is crazy, ready to get started. Y'all want me to keep going? Maybe. I will tell you that I just want to get your feedback on a couple other little things that may work, because we saw the whole we had 5 PBMs, right? Y'all know the story. Okay, so we come into one PBM. We just got the largest rebate ever given to the state of Kentucky in drug rebates this year in the history, because we had one PBM. And why is that? We were able to nail down on the RFP. We were able to hammer down on the criteria. We were able to work with one person. And then we had one drug list, right? We didn't have 5 different drug lists. We were able to go to our interstate commerce compact and work with them on some more aggressive rebates. So all of that's good. I see that same thing possibly being available. I bring that up because I see that same thing possibly available to us from an MCO level. And I know in this in this committee, a certain senator, he's here today, has brought up legislation to reduce the number of MCOs so that, again, we can get a handle on this. You can't hardly get a handle on it when you got 5 different sets of rules running all over the state. And we found that with our PBM, and we're couldn't be more excited, and I'm thankful for Medicaid and everybody else that worked on that, Senator Wise and everybody else. So I would like to hear your feedback. And I don't want to hear that you can't service the state. I know better than that, okay? I know 3 MCOs can service the state just fine, okay? So don't tell me that, because that probably will keep me on here. So just give me your idea of what do you think 3 MCOs would do? Do you think it could have a similar effect as we, to be able to establish maybe some more guidelines that are easier? Because administratively, and again, I could get off on the PAs. I'm not going to do that right now. But tell me what you think about 3 MCOs. I'm done, and thanks.
Yeah, thank you, Representative Sheldon.
Thank you.
One thing I've just mentioned on the 3 MCOs, there's active litigation that's still being proceeded related to the number of MCOs. In regards to the single PBM, one thing I would caution you and just make sure you're aware of. So I think you're well aware that the PDL is now prioritized around brands.
Mm-hmm.
So while you're seeing significant increases in rebates, what we also need to do is study the impact on the underlying reimbursement costs to providers into the PBMs. What we've seen, at least from a healthcare perspective, is rise in cost. So while you're going to have an offset of rebates, you're also going to have to look at the costs that are going up within managed care associated with that transition.
And I'm glad you brought that up. And I didn't mean to. I'm certainly aware of how that works. The fact that we have control of that PDL, and the fact that there's more brands probably on it now, is because it does increase the rebate back to the state.
Sure.
It increases a little bit of the obviously the expense to you, and then that's but we have faith that you're gonna balance that out, and I think we've seen enough studies to know that can and will happen. But thank you, that's a good point. Yeah.
Thank you, Representative Sheldon. We've got 5 other committee members that want to speak to this. I'll go first to Senator Alvarado.
Thank you, Mr. Chairman. And thank you all for being here. I've been writing notes furiously. And I tell you, it gets difficult for me to hold my tongue on a lot of this stuff. But I wrote down here, I know the first thing I wanted to talk about was the penny of profitability and why the stringent contracts and how we have some of those. And I think it's important for some of our members who may not have been here around 2015. I got elected in 2014. And in 2015, we quickly saw the profit margins for the MCOs when it came to Medicaid here in the state of Kentucky. And so I guess part of this is a relationship that has gone awry from the beginning. It's one partner who cheated on another and now saying, hey, look, trust us now at this point. And it's awful tough to rebuild that trust, particularly when there's efforts to increase transparency on all kinds of aspects of this and a continued resistance for that. But back in 2015, the profit margins for our MCOs, they were making $850 million, I think they made one year. And if you're looking at one penny, our annual budget for Medicaid is $11 billion. Let's remind ourselves of that. $11 billion per year, $2 billion of state funds, $9 billion of federal funds, all to manage about 1.5 to 1.6 million patients. So you're making about $110 million in profits that we see. That's what's straight out there. And it's probably more than that, because I know that some of our MLRs, some of our partners, the first thing that you do there is say, before we do anything, some of the MCO partners are making sure they get that profit margin first. I wonder how we would feel if our providers and our doctors out there, or our nurses or our hospitals said, hey, whatever care we're going to provide, let's make sure we set aside our profits first. Whatever we got left over, then we'll apply that to our patients that we take care of. That would be an outrage for any of us, an outrage, absolutely. So if you're complaining about the penny, I remind people that's $110 million in profits now that we see. That's not hidden stuff like we've discovered with PBM management and lots of other things where monies are channeled in backdoor ways for you all. If this was not a profitable thing, there wouldn't be this fight from a lot of our MCO partners to come in and try to prove of their worth and try to prove that worth. Because you guys are making good money here in the state of Kentucky, and you have for a long time. The profits were 8 times that amount easily, just 5, 6, 7 years ago. And the response when we asked them, everybody then was, well, that's what our contracts allowed. That's rough for me to swallow. It's particularly in a field where I try to apply an ethical standard to how we do things in the world of medicine. I want to go back to your raising quality standard slide, if you could pull that up, on the value of managed care. I think if you guys want to put that on the screen, because I'm away and I'm trying to find it on my computer, but it's more difficult. I think you all had put there the raising of quality standards. Is that over a certain period of time? Is that over the past year? I mean, you're saying you're controlling blood pressure 9% better, 18% in cervical cancer screenings, 14. I think I wrote down here child immunization rates, 34% in teenage well child checks. Is that over the last year, over the last 10 years? When are you comparing that data from?
Yeah, Senator Alvarado, I appreciate the comments. We don't have the slides up. The stats are sourced at the bottom of the document. Most of the ones within the quality program, it's a 4-year look from 2016 to 2020. So we try to have a view that separated non-pandemic utilization, because obviously HEDIS scores, CAP scores have been impacted. So we took the previous 4 years and provided a study of specific HEDIS indicators during that period. Some of the ones on the right are really focused around when we transitioned fee-for-service to managed care. So we're trying to give a view of what would have happened in Kentucky if we remained within fee-for-service, like some other programs that have remained there within other states. So the sources at the bottom, I can actually pull those out and send those to you just to reference where we got them from.
Yeah, I think the main thing is that's over a 4-year period of time. That means that for those reductions, and I'm guessing you're not highlighting diabetes, you're not highlighting reduction in obesity or heart disease, which is the number 1 killer, or things like lung cancer or some of those things. Those are the top killers for us in the state of Kentucky. You're choosing to come before our committee to highlight these outcomes. What we're saying is this is what we could do. So I don't know where diabetes, heart disease, all the things that we hear about, hepatitis C, other things that are killing Kentuckians right now, we're not highlighting those outcomes. They're either worse or they're not very impressive, or they're the same as how they've been before. And so my argument is, if we're spending $11 billion, $11 billion is what our budget is every year when it comes to Medicaid. That means over a 4-year span, that's $44 billion that we've spent for these outcomes. Do you think that's worth it? Do you think that these are nice outcomes, they're great. We've got, a 14% increase in child immunizations, which I wonder, because my pediatrician buddies tell me that we're worse on outcomes when it comes to vaccinations in our state, and a 34% increase in teenage well visits. That's all nice, and that's wonderful that more teenagers are coming into doctors' offices for their annual well checks, and 9% better blood pressure control. That will help. Is that worth the $44 billion you spend in Medicaid that's gone through MCO hands for those outcomes?
Senator Alvarado, what I would tell you is that we believe with the premium provided, we are bending the trend associated with health outcomes specific to Kentucky. We are baselining Kentucky versus Kentucky, and ultimately to drive a lot of the discussion points and issues that are prevalent within our populations, we're also going to have to go after social determinants. So we're going to have to figure out how we address tobacco utilization, obesity, poverty. I'm happy to share the full results. You're right. We've highlighted some areas where we have excelled. In other areas, we've improved. And there are areas where we have maintained. But in general, I would say that the investment that's been made in managed care has been successful for driving both quality and outcomes in Kentucky.
Yeah, so it's been 10 years. All the things you just mentioned, all those social determinants, we were hearing committee hearings on that 10 years ago. You all were aware of that coming into the state of Kentucky. So that's part of the argument. I think when you hear Senator Meredith and myself get so excited and so upset about this, is that those were all things that were known when you all came in and you said, hey, we're gonna drive that. We're gonna manage care. That's what you guys are called, managed care organizations. I would argue you're managing money, not care, because it's been $110 billion over a 10-year span that's been spent on Medicaid for roughly anywhere between 1.3 to 1.6 million people total that have received it over a 10-year span. So $110 billion spent, easily over 1.1 billion, probably closer to $2 billion in profits for the MCOs for these managed care outcomes over 10 years, these last 4 years even. That's my argument, is that I don't see that we're seeing any improvement or any quality measures that are improving for us. All of those determinants, all of those things you've mentioned have been known. So these are things that you guys have known about from the beginning, and not much has really changed for us. And that's why our argument is there really any value? I haven't seen it because I'm still practicing. I still see it out there. The other thing, I know we had some discussions on behavioral health stuff. I mean, we've had to pass laws on so many laws we've had to pass really to keep you all honest, to keep you guys honest in terms of your contractual obligations, keeping things honest and just trying to find ways around it. It's like whack-a-mole when it comes to the insurance lobby for us. But when it comes to things like mental health parity, we have to pass laws to make sure that our MCOs and our insurance companies are treating mental diagnosis equal to other medical diagnoses. I mean, to talk about, hey, people are getting readmitted, we understand that substance use recovery, that people have frequent relapses. So it's not one of these disorders that, hey, just suddenly it happens once and you're fixed. No, that isn't how it goes. It's a lifelong fight for sobriety. People get readmitted over and over again. And if we're making headway, we've had a 49% increase in fatal overdoses this past year. Plenty of things with COVID, but they're trying to provide more recovery issues for this as we're going through with it. Also talking about kids that are being admitted, and again, under the age of 18, that's all great. I'm wondering how big of a ticket item that is truly for Medicaid overall when it comes to a lot of those issues. I mean, the number of kids that are involved in that I think are relatively small compared to the $11 billion budget we're talking about every year. And I think one of the comments was made by the rep from Anthem there, talking about that's great that we have 8 new nurse practitioners in Eastern Kentucky. That's wonderful. And I know it's a small subset just from one visit. I get that. But I think your comments also are to the fact of, when Senator Meredith says, why would a provider want to go to rural Kentucky right now? You don't see people hanging up a shingle in Eastern Kentucky on their own individually. They can't afford it. It's impossible to afford. And again, we don't get to set aside our profits first and then say, what do we get in? And the rest will apply to care. Most medical providers don't have that luxury. Insurance companies use that luxury because they have it. And there's always a profit there. And I understand that you have to be paid for your services as well. But when it comes to providers, it's no longer a tenable kind of system really for our providers anymore. And that's why you're not finding people hanging up their own shingle. Everyone's always relied on the goodwill of medical providers, on the, oh, you took an oath, or someone, you did this, you got to do this, you got to do it. And that's what we've relied on forever. And that goodwill is running out for our providers, for our nurses, our doctors. We're seeing it quickly go away. And so I'm preparing you all, because I think the thing you got to look for the future is here. You're not going to have many providers willing to practice in the state of Kentucky. And if some of that 1% profit, I know, which may seem like a little bit, again, you guys made 8 times that amount for years in the last decade. Hopefully you've got some of that on reserve. Some of that probably needs to come back and be spent on the actual health care instead of on profit margins. Mr. Chairman, I could go on for an hour. You know me, I'm going to let it go at that. Plenty of more questions on the presentation.
Yeah. And I do appreciate you greatly and appreciate the comments. Representative Prunty, you have a question, comment?
Yes, I have a few comments and then a couple of questions. We keep hearing in Kentucky about the real shortage of providers. And then there's another layer of shortage of providers who are willing to see the Medicaid patients. I have a couple of suggestions. I've heard from providers in my district for years, can the forms be streamlined? And the prime example I will give is that, why do you have to redocument that somebody's got an amputation? Once it's cut off, it's not growing back. And so could you look at your forms and some of the things that are redundant and duplicative for providers? What's the time frame for credentialing? That if you all had to wait on your reimbursements the same amount of time that people get credentials, maybe you'd speed that up. Number 3, I guess the question is, and I guess this is to Jeb Duke, you were talking about the savings. How much of the savings are clawbacks on legitimate services for providers?
I apologize. Could you repeat that question?
Knowing firsthand that many primary care providers were forced out of independent practice because of clawbacks from Medicaid, how much are the savings due to clawbacks for legitimate services?
I don't have that answer specifically with me today. What I would generally say about how savings are achieved through managed care, it's about healthcare trend over time. So if you think about a 10-year period and you have a 3% versus a 4% trend, it's the cumulative effect of how managed care is able to control costs through management of services. That's how you get to these larger numbers. It's not about specific clawbacks or specific utilization management programs. It's about, over time, what does healthcare costs look like in Kentucky in 2011 versus what it looks like today? First, what does it look nationally? What does it look like within their program? So that's what we're suggesting here from a healthcare savings perspective, is that if you look programmatically over time of healthcare costs, Kentucky versus other similar states, that's how we've achieved savings attributable to the state budget.
Okay. As far as prior authorizations, this is my last question, Mr. Chairman. I serve on the Severe Mental Illness Task Force, and we heard from folks in committee last week about the issue of prior authorizations getting in the way of treatment. In particular, I have a constituent whose sister-in-law was going from being incarcerated to rehab, and that's maybe something we have to look at as far as her losing her Medicaid during incarceration. But the prior authorization period was going to be a big gap between her leaving jail and going to rehab, which would have been an opportunity for her to reuse. Is there any way you can address, talk about crisis care? To me, that's an issue that's real when we're talking about substance use disorder and trying to get people help. Could you address that, Ms. Stearman?
Yes, absolutely. And thank you for the question. I am happy to report that it is actually been a known issue for some period of time about the complexity and difficulty that we have transitioning individuals from an incarcerated status back into a community status. And the department has been extremely proactive about trying to remedy some components of that. And it does have to do, as you stated, with that loss of eligibility, the temporary ineligible period while our members are in an incarcerated status. We currently have, the department has submitted for a 1115 waiver to CMS, very specific to that treatment need to try and resolve that. That would allow us to be able to cover those individuals while they're in an incarcerated status for very specific mental health, behavioral health conditions, including substance use disorder. And that would allow for that temporary ineligible period to be somewhat taken away and allow us to cover services not only while they are incarcerated, but also to allow us to work to do that transition timely. We've also been working with the department, all of the managed care organizations have, to make sure that we are getting timely notification when we have an individual coming out of an incarcerated status. And in fact, in some of the pilot programs, prisons and jails across the state of Kentucky, with the collaboration with the National Governors Association, we have a pilot that's going on right now where the Department of Justice is actually doing assessments and surveys with those individuals as they approach their release date. We get notification if one of our members is imminently going to be reinstated to our Medicaid plan prior to them leaving, and allow us to help arrange both transportation and get any kind of appointments, assessments set up. Right now, obviously, there is no authorization required for those services, so they can show up on any day and get that covered without an authorization period. But we are trying to remove some of those barriers by allowing that to happen in a timely way for those individuals, because we know that that period of time where they may not be able to access care is the time where we see those unhealthy outcomes be the potential for our members. But I will say that's something that we actively engage on, and our providers are aware. For a substance use disorder service, we have no less than or no greater than 24 hours to even review and give a decision on that. The majority of providers will initiate care and start that with Medicaid members even prior to receiving that authorization.
That's encouraging. I believe her situation happened prior to COVID. So I appreciate the fact that you are looking at that. I just want to echo about the single credentialing source and the audit issue that Representative Sheldon brought up. I have constituents who are crying about that situation, and just appreciate the opportunity. Thank you, Mr. Chairman. Appreciate it.
Thank you, Representative Prunty. Representative Wilner, I believe you're next in our queue.
Thank you very much, Mr. Chairman. And thank you for the presentation and the opportunity to hear this report. I share a lot of the frustrations that my colleagues have already expressed, so I won't rehash them here. The denial of services by licensed psychologists when we know it's so difficult for these mental health services to be provided, and then for people not to be paid for their work. I do have specific questions, which I'll just mention now, and I'll follow up later for answers about this, but I wonder what we're doing for the small segment of Kentuckians with severe and persistent mental illness who need ongoing treatment. It's not, 6 sessions and they're done. This lifetime worth of services that are needed to keep folks in recovery and to be able to function in society. And so I have a lot of concerns about that. But a higher level question I have, we hear about the audits. We know that managed care holds providers to very specific standards, expects lots and lots of reporting. I'm hearing about the reports that you're required to submit, but I wonder what the specific standards are that we, the state, that the cabinet, that this committee is holding the managed care organizations accountable for. I would hope that we're holding you accountable for closing equity gaps between rural, urban, between black and white, other kinds of equity gaps. And I just wonder if you could provide me an overview of what the specific standards and criteria are that you're required to meet.
Representative Wilner, I can get back to you from a perspective on what our requirements are. It may be a follow-up on the audit and fully understanding what audits we're discussing. I don't know if these are post-pay quality audits or if they're credentialing audits, but I'm happy to investigate and to give you a full report, both of what's required from us and secondly of what you may be seeing from an audit perspective. Because I do think that is something that probably needs to be reviewed is as we've removed prior authorizations, what's the impact on the back end for investigation where we do see potential for fraud, waste, and abuse. Part of the requirements of managed care, as well as for fee-for-service Medicaid, is ensuring that fraud, waste, and abuse is investigated, and what's the appropriate way for doing that now that we're in a pandemic and we have a situation where we've had 18 months without a level of authorization.
Thank you. I'll look forward to the follow-up information. I appreciate it.
Thank you, Representative Wilner. Representative Gooch.
Thank you, Mr. Chairman. I've been on this committee for about 3 years, and it's not always a fun committee for me, but I come and I listen, and I try to learn something and try to be respectful. And I serve on this committee because I think it's important that at least a couple of members on this committee are not providers. And that's why I stay here. And, I came here in 1995, which was right after then Governor Burton Jones did his health care law, House Bill 250. Exactly. How could I ever forget that? House Bill 250. And, it really was billed as health care reform, but there wasn't a damn thing about it that was health care reform. It was about health insurance reform. And we're still seeing that same thing today, even after Obamacare. We'll never call it affordable health, Affordable Care Act, because nothing about it was affordable. But we have to understand at some point that there are a lot of problems in the healthcare from every level, the provider network or whatever, but some of these things that really affect this are societal problems. The fact that doctors won't go back into rural Kentucky because 80% of their patients are probably on Medicaid who doesn't, or Medicare, that don't pay the full cost. What that really means is that they go to an urban area where most of the people have private insurance because their employer pay for it, where the cost can be shifted from underpayments from Medicare and Medicaid to the private insurance sector. Now, is that a problem of the insurance industry, or is that a problem of societal problem there? Why is it that we have the same type of situation with a voluntary market where people choose whether or not to buy insurance? We've found out through our reforms that the young and healthy will not pay an inflated cost for a product they don't think they need because they think that nothing's going to happen to them. And every time we've done these bills, whether it be Obamacare or whatever, we've doubled and tripled the cost to the young and healthy. That is a societal problem. And I think that at some point, I'm not arguing about whether you guys made too much money or some of the audits you do and some of the other things that you do are right or wrong, but I am saying that a lot of the issues that we have are societal problems in nature. And that means that society should help solve these problems. And we can't just look to the insurance industry or the MCOs or this group to solve these problems. We're going to have to tackle them ourselves and realize that we have skin in the game, and there's some things that we may have to do to make sure that people are insured or whatever. But what we've done in all these reforms has not worked because we've never done health insurance reform. It's always, healthcare reform. It's always been health insurance reform. So I just hate to see one section of the group, one industry of the group, saying, why is it that you haven't solved this problem when the issues are much bigger than that? And that's all I have to say, Mr. Chairman.
Thanks, sir. Last question from Co-Chair Elliott.
Thank you, Mr. Chairman. I've enjoyed the discussion. I come to this from a different area as well. I'm a lawyer, so I'm outside of the healthcare industry as well, and I recognize that Kentucky is a very poor state, and we have very unhealthy citizens, and so that's a charge, I think, to all of us to do better to improve those outcomes. And so you have a very difficult job, I think. My question, earlier in the presentation, a comment was made that managed care had saved Kentucky between $300 and $400 million. I'm not seeing that statistic on the slide. Was that in the most recent year, or where was that number generated from?
Representative Elliott, I appreciate that question. It's a recent study that's been conducted. We'll publish that this week, and to make sure that you get a copy of that, and everyone on the committee as well. Okay. The study, the review period was 10 years. It was transition fee for service 10 years ago, 2011, to pre-pandemic 2020. So we didn't include, obviously, the last 18 months where you have seen a shift in cost. So it's exclusive of the pandemic, but I'll share that study with the full committee.
Because that looks like that's a huge increase from 16 and 17. Is that, I think, 184 million in 16 and 194 million in 2017 savings to the Kentucky taxpayer from managed care. So that would be a huge increase, it looks like. So I would be interested to see those statistics.
Absolutely. I'll share that with the full committee. Make sure you get a copy.
Thank you very much. Thank you, Mr. Chairman.
Thank you. Unlike my co-chair here, I have not enjoyed this dialogue. I'm sorry, but I had a conversation with someone yesterday. They asked me about this agenda, and apparently every time I put out an agenda, somebody thinks I've got a hidden agenda beneath it. It's not. What I wanted to talk about today was prior authorizations, network adequacy, and sufficiency of substance abuse. I did not intend to go out in the direction that we went by any means. However, if you're going to start your presentation by doing a commercial for the MCOs and patting yourself on the back, I got a problem with that. I think you're being disrespectful to this committee. I think you're being disrespectful to me. That's not what we ask you here today, and it bothers me greatly. I'm not after the MCOs. What I want is a symbiotic relationship between the MCOs, healthcare providers, our legislature, and our cabinet, and I'm not seeing that at all. I'm sorry. Again, you give me lip service for 5 years about you want to really help rural communities, and I've seen nothing, absolutely nothing. If anything, the burden has become greater. You may have heard testimony last week. Hospitals lost $1 billion during this COVID crisis. The system's going to collapse, and I don't think there's a single person sitting at that table cares. Particularly, you don't have any idea what impact that's going to have on rural communities, what impact it's going to have on the state. So while I appreciate your testimony today, I think you erred greatly by promoting yourself. I'm sorry. But I appreciate you being here, and I'm sure we're going to have future dialogue on this. Thank you.
Yes, sir. Thank you.
Next item is our Managed Care Provider Action Network with Dr. Sheila Schuster and Emily Beauregard, and I think they're testifying remotely. And ladies, my apologies for keeping so long, and also my apologies that we'll have to cut you short because we've consumed too much time on this particular subject. So I can give you probably 10 minutes, and I hope that's sufficient for you. But if you would, please identify yourself for the record and proceed.
Good afternoon. This is Sheila Schuster, and I don't think my video is working. So you'll have to just listen to my voice. I don't know what's happened here. I'm going to skip the first couple of slides because it lays out the network requirements. I do want to say, since the issue came up about prior authorization, And this committee was kind enough to ask me to testify on that topic. That it pains me to hear the MCO say that that not having prior authorization has actually hurt Kentuckians. They didn't talk at all about the topic that we talked about that is so needed in the behavioral health world, and that's targeted case management. It is a cheap service, but it is a necessary service, just like insulin is necessary for diabetic patients. So I'm going to keep coming back to that. Also, as we know with substance use disorder, if there's the slightest delay between the time that somebody thinks that they want to get services and actually gets into them, they very often drop out and don't get the services that they need. I'm going to start with the Deloitte Workforce Capacity Report. This was mentioned by Senator Alvarado recently in another committee meeting, published in 2013, and we've not had anything like this since then. But they gathered their information from the licensure boards of each healthcare profession. And I would just point out that none of those licensure boards collect the kind of information that we really need to accurately assess our workforce capacity. We don't have the addresses of all the practice locations where the provider works. We don't know whether they're working full-time or part-time or whether they're practicing at all. I continue to keep my license so that when I testify, I can say I'm a licensed psychologist, but I have not been in clinical practice since 2000. So I'm counted in that network, if you will, of workforce, but actually am not practicing. We don't get into the specialty areas of practice. We don't actually ask providers what aspects of their practice meet specific patient needs. Those for whom English is a second language, the LGBTQ community, those with disabilities, ages. There's a big difference between being a child provider, as Senator Alvarado knows, as a pediatrician. I was a child provider all the years I was in practice, 27 years, and those who treat adults, and the cultural sensitivities that were mentioned by the MCOs. We also need to know whether they offer telehealth. So I think the data in that report probably is an overestimate of actually the number of practitioners and doesn't give us a distribution because they use only one address, usually the home address. Next slide, please. Thank you. They define mental health providers as psychiatrists, psychologists, LCSWs, counselors, marriage and family therapists, and alcohol and drug counselors. They did not include psych mental health APRNs, of which there is a growing number, nor licensed mental health professionals working under supervision. When defining the need for mental health for each county, the study puts all of the mental health professionals together as if they all provide the same services, which they do not. We also don't know, and this was a point brought up by Representative Prunty, whether these providers take Medicaid. And we hear increasingly that there are providers that do not take Medicaid. I will tell you on the behavioral health side that part of that is that the rates for behavioral health services, for instance, for delivered by the community mental health centers, have not been increased since 1999. So that's 22 years of the same rate. Now, you all know that the cost of doing business has increased dramatically during that time. So that's a big reason why people don't take Medicaid. Next slide, please, Emily. So I'm going to give you an example. You may remember in the 2020 General Assembly session, you heard some excellent testimony from Melissa Cahill, who is the mother of a daughter with severe eating disorder. This was a bill that was brought by Senator Julie Rocky Adams, and through passage, and I think it passed the House and Senate unanimously and was signed into law at the end of the 2020 session. It established the Kentucky Eating Disorders Council. And one of the things that that council has been trying to do is to make sure that we have adequate treatment in Kentucky for these complex life-threatening disorders. They currently affect about 6% of Kentuckians at any given time, but some 19% are going to have this issue at some point in their lives. We think of eating disorders typically with females in adolescence and young adulthood. although increasingly, and this is scary to me, children as young as 8 are being diagnosed. And these disorders, as you know, have both a psychological and a medical component. So you need a wide range of providers. You actually need a team of physicians, psychiatrists, psychologists, therapists, and dietitians. You also need a continuum of care from outpatient therapy to intensive outpatient therapy, partial hospitalization, and inpatient hospitalization. There are very few eating disorder providers and services available in Kentucky. At this point in time, there are no inpatient programs in the state. So people are having to find out-of-state facilities. They're trying to get them covered. I'm not sure Medicaid is paying for any of those out-of-state inpatient facilities. Private insurance will, but they involve sending the youngster or the young adult out of state. Nor is there a partial hospitalization program. There are a limited number of outpatient therapists, and there's only one designated intensive outpatient program in the state. That IOP provider has tried for the last 9 months to open a partial hospitalization program, but the MCO reimbursements are too low to keep the program sustainable. MCOs want to reimburse for the 6 or 12-hour daily program at a lower rate than they do for IOP, which is offered for 3 hours a day. And even that is a barely sustainable rate. So I was interested to hear the MCO say that if a service is not available, that they are willing to pay higher than the going rate, but that is obviously not the case with eating disorders. And remember, these are life-threatening, not only on the mental health side, but literally people can starve to death with severe eating disorders. So I just use this as an example for a big problem that we have. And one final slide, please, Emily. So one of the problems we have, and I get calls all the time, even though I'm not a provider, I get calls from people that know my name, and they'll say, I need to find a mental health provider. I don't know where to start. And I always start with, what's your insurance? And they'll say, well, I called the number on the back and they gave me 2 names, or they gave me 3 names. And I always say to them, call them back and tell them you want the full provider directory. People need to know what the range of services are and the range of providers. We know, and we hear all the time from people looking for services, that they call and the providers have stopped practicing, they've passed away, they've moved, or they have stopped taking new patients. Some of them will even say, I never heard of that MCO. I didn't know I was listed in that provider directory. There was a recent whistleblower lawsuit filed by an MCO employee in Florida that alleged that many providers listed as in-network either did not have contracts or not pediatric physicians, or were out of state, retired, or dead. The conclusion was that there were 10,000 children in Florida who did not have a pediatrician as their primary care provider. MCO provider lists do not provide sufficient information. They're not differentiating behavioral health providers in any way in terms of those who are prescribers, those who can do psychological testing, and those who are doing therapy. Oftentimes, providers limit the number of Medicaid members they will accept because of the low payment rates. So even if they are taking new patients, they may turn away a Medicaid member. So I'll turn it over now to Emily Beauregard. Thank you.
Thank you, Sheila. Thank you, Mr. Chairman and members of the committee, for having us today. We really appreciate the opportunity to talk with you about network adequacy. My name is Emily Beauregard. I'm the director of Kentucky Voices for Health. We're a coalition of consumer health advocates, and a big priority of ours is making sure that every Kentuckian has access to affordable, high quality, equitable healthcare without barriers. And so you can imagine that network adequacy is critical to that. And making sure that people have a provider, when they need it, are able to access that care is absolutely essential to getting good health outcomes. So what I wanted to start with today is sharing some results of a recent survey. You may know that DMS is required to contract with a third-party external review organization, or an EQRO. Kentucky currently contracts with a company called iPro. They have for many years. The role of an EQRO is to monitor quality, timeliness, and access to healthcare services that are provided by a managed care organization. And one element of this work is a secret shopper survey, which iPro conducts annually, although each year it focuses on a different set of specialties, so it's never comprehensive for all types of providers within 1 year. And what I wanted to share today is the most recent survey and the most recent data that we have from 2020. iPro randomly selected 1,250 providers, including primary care, pediatricians, OBGYNs, behavioral health, and SED providers. And these providers were all contacted to make appointments for routine, urgent, or after hours visits. And they were also asked about the availability of scheduling a telehealth visit. So here are the results. The survey found that about 35% of the providers called for routine visits were able to be contacted and an appointment scheduled within 30 days. About 20% of the providers called for urgent visits were able to be contacted and an appointment scheduled within 48 hours. About 49% of the providers called for an after hours visit were able to be contacted and an appointment scheduled for after hours. And then the surveyors were only able to set a telehealth appointment about 18% of the time for routine visits and about 4% of the time for urgent visits. Now, when we look at these survey results, keep in mind that the industry standard is 80%. So we are far, far below that threshold. This is the case even though Medicaid requires MCOs to comply with the access standards that were provided in the previous presentation and on our slide deck for 95% of enrollees. So our threshold is technically higher than the industry standard, and yet we're doing much, much worse. So it seems that on paper, MCOs are submitting what is required, technically required for network adequacy on a regular basis, but that doesn't seem to be translating into what consumers are experiencing, at least not generally speaking. There are probably a lot of factors that play into this, but when an MCO's network is found to be inadequate, they're required to submit a corrective action plan within 30 days. The question is really whether these corrective action plans are being followed by the MCO or enforced by Medicaid. And knowing that iPro has been conducting these secret shopper surveys annually, I think we should be expecting a much higher rate of compliance. Now, when patients are unable to get an appointment that complies with that time and distance standard that's set by DMS, it's the responsibility of the MCO to approve an out-of-network provider. We've heard that already. What we don't know is whether their members know that that's an option, and I would guess that most do not, or what a member needs to do in order to get that out-of-network provider approved. So I would guess that there are many times when someone just doesn't get the care that they need in a timely fashion or at all. So based on what we know about current network adequacy requirements that are laid out in statute and regulation, the limitations of workforce data being collected by licensure boards, and the results of that most recent secret shopper survey, we have 5 recommendations that we believe would greatly improve timely access to care that patients really need. So the first is to mandate that all healthcare licensure boards collect the following information that Dr. Schuster went over. It's just bottom line, absolutely essential that we get better workforce data in order to understand the scope of this problem and be more targeted in our solutions. Our second recommendation is to require that MCO provider directories categorize provider types more accurately and are specific to the services provided. So behavioral health categories, for example, prescribers should be limited to psychiatrists and mental health APRNs. Psychological testing is limited to psychologists. Therapy or counseling is provided by all behavioral health professions, and then you have substance use disorder providers. We also need categories similarly created for dental and other specialties. And in all categories, as Dr. Schuster mentioned, it's incredibly important to make a distinction between services provided to adults versus children. Our next recommendation is to establish a permanent and more comprehensive state-funded secret shopper program to conduct annual surveys of published provider directories. And I think what's really most important here is that there be more compliance and that DMS provides stricter enforcement. And so, Chairman Meredith, I know that you are a fan of the ASO model, as am I. Connecticut has done an excellent job with their secret shopper surveys, and I think we could learn a lot of lessons from how they are able to not only conduct the survey, but take that information and make improvements in their networks. Our fourth recommendation here is to require MCOs to provide their full provider directory to consumers at their first request. And these directories should be updated at least monthly and made available in paper and electronic formats that are easily accessible. And our final recommendation is that any legislation should include these guidelines for network adequacy that have been developed by the National Association of Insurance Commissioners. That includes establishing requirements that guarantee continuity of care for individuals who are in the midst of an episode of care, in the situations where a provider is dropped from their network or leaves the network. That we require providers to notify health plans and patients when leaving a network for any reason. That we require health plan provider directories to be updated regularly and made publicly available. That we adopt standardized health plan reporting requirements to monitor frequency of out-of-network services and network adequacy. And finally, establish a comprehensive and standardized list of complaint codes to track consumer complaints related to network adequacy and access to care. And of course, I think that these should be public reports. And with that, we would be happy to answer any questions that you have.
Any questions from committee members? Not seeing anything, and again, I don't think that's an indication of lack of interest in your presentation. It certainly is a serious topic, and I've always enjoyed my conversation with both of you regarding this, and I know the discussions we've had at Health and Welfare and also Budget Review for Human Services has touched on this problem, and I'm hoping and praying that we can come up with some good solutions when we come back in session in January. But thank you for your presentation today, and I'm sorry that I had to limit you in your time, but appreciate your input. Thank you. Next item on our agenda. Steve, just keep walking the right direction. We're talking about the effectiveness and sufficiency of substance abuse disorder treatment as provided by our MCOs. Steve, please introduce yourself for the record and please proceed.
All right, let me get myself up here. Again, I'm Steve Shannon. I'm the Executive Director of CARP. CARP is Association of 11 of the 14 community mental health centers. I do not have a PowerPoint. I like to speak this way instead of using a PowerPoint. I have sent my comments, so you'll have those for the record as well. Typically, I'm a community mental health center guy. I talk about community mental health centers. I've been doing it for a quarter of a century. I can tell you we serve 175,000 people a year. Mental illness, addiction, intellectual developmental disabilities. 7,000 employees, 300 dedicated board members. Talk about those things a lot. I'm passionate about community mental health centers. But today I'm going to kind of step out of my lane a little bit and talk about MCO network adequacy, came up, effectiveness, and the S word, what is that? Sufficiency of the substance abuse network. Substance use is a big deal. I'll tell you how big a deal it is. I'm probably the only guy in the building who travels with Narcan. Someone overdoses on opioid, I can save their life. I encourage you all to get trained in Narcan. It's not hard to do. Straight up the nose. Substance use matters. People are dying. We need to make sure they access the treatment. It's a big deal, I think. But the mental health center serves 31,600 people, average 3 years before COVID hit, for substance use treatment alone. So it's a big deal. We do inpatient, we do outpatient, we have residential services. But there's two other provider networks I want to talk about in terms of the sufficiency of the substance abuse managed care network. And sufficiency is what I want to talk about. And these are behavioral health service organizations. That's a new licensure status effective 2014 when Medicaid was expanded. It's a CMHC lookalike. Probably offends my BHSO friends to say that. They do mental health and substance use services. They do they do outpatient, individual therapy, group therapy, intensive outpatient services. There's 117 of those statewide. 117. 14 mental health centers serving all 120 counties and about 117 behavioral health service organizations. There's also licensure status, alcohol and drug entity. I want to talk about that. 588 organizations are licensed as an alcohol and other drug treatment entity statewide. There's a lot of providers. So I contend, Senator Meredith, I probably shouldn't say this to you right now, perhaps there are sufficient providers statewide. Perhaps. I know, I'm sorry. I almost ripped those pages out, but I decided not to. Perhaps there are sufficient providers available. Now, what I can't tell you is how many people those folks served, behavioral health service organizations and AODEs. But to answer your question about how many are there, I went by county. I counted the AODEs, because the CMHCs are easy. It's all 120 counties. They're covered, all 120 counties. Alcohol and drug treatment entities and behavioral health service organizations, they are in 92 of 120 counties. There's 28 counties that have a CMHC, but not another provider in that county. So that's a concern. Those counties, you could probably guess, half of them have populations ranking 95th to 120. So small rural counties don't have the same access as large urban areas. That's a lot of people providing those services, essentially. If you look, and some of those, congratulations to my friends at corrections and local jails, they have AOD licenses, not necessarily from them to have one, but they got one anyway. CMHC, some of those carry both, AOD and CMHC. So 588, maybe the actual number providing services in the community is lower than that, 550, maybe 540. I point those out because the only reason you would get a BHSO or an AODE license is to add Medicaid to your book of business. It's not a commercial insurance identifier. They don't know what that means necessarily. They may look it up and understand it, but that doesn't get you on their network if you have that as an AODE or BHSO. So it's the Medicaid business. And that's been a huge growth. Unfortunately, people see that the opioid epidemic and expanded service is a good thing, but that's what drove the increase in AODEs, 588. So I think there are. Now, interesting, there's 4 contiguous counties in West Kentucky that only have a CMHC meeting their needs. 3 in Northern Kentucky, only a CMHC. So it's not everywhere. Jefferson County has 88 AODE licenses, 88 in addition to 7 county services. Fayette County, 51 AODE, alcohol and drug treatment entities, in addition to New Vista, the mental health center there. There's a lot of providers. They're not well dispersed. 30 or so counties have 1 AODE or BHSO in addition to the CMHC. So what's the access questions there? But all I can tell you, Senator Meredith, member of the committee, is they have a license. Dr. Schuster and Emily Beauregard nailed this issue before I got here. We don't know what those folks are doing. We don't know how many people they're seeing. We don't know who they have. Are they prescribing medication? Are they doing medication-assisted treatment? A huge deal in the opioid world. Are they doing that? I can't tell you that. But I can tell you there's a huge number. I don't know the extent of the billing they're doing. I don't know. I can tell you the CMHCs are billing Medicaid. I can tell you that. So I think there's a lot of people who are licensed to provide services in the state, both urban and rural settings. I just don't know how many of those AODE and BHSOs, how many people they're serving. It costs $500 to get a license for a business. That's not very much, not a lot of money. AODE, you pay $500, you can get additional sites for $80. Mental health center could have 5 of those licenses for about $900. I don't know how many people are being seen. I just don't know. I do know treatment works. I do know people who go and they improve. And I want to echo what Senator Alvarado said. It is an illness of relapse. That's what it is. People are going to relapse. It doesn't matter. They're going to relapse. They will recover, right? But so I can't answer that question for you. But I can tell you how many people have a license and went to the challenge of going through that process and becoming a licensed provider. And that's a sufficiency measure. But I don't know what they're doing. I can't tell you that. I can tell you what CMHCs are doing. A residential program. You know why some residential programs? There's less access during COVID. The wall in my office is adjacent to a women's residential substance abuse program. It just happens to be. My landlord happens to be a mental health center. I have a program right next to me. They're set up for 2 women per bedroom. COVID has 1. Less access. Men's program up the street. Less access during COVID. Okay. The other thing that's happened in terms of sufficiency is managed care has changed program models. There's an adolescent program in a rural county, exceptional program. Local school system bought into it, sent a teacher to the program. It was intended to be a 90-day residential program. Some kids stayed 180 days and got treatment, right? Stopped using drugs during that period, got better. You know what else they did? They picked up high school credits. They had 16 kids and a teacher, online learning, long before anyone knew about it. They picked up. 1 kid graduated high school. The local school system said, he's not welcome here. They did a graduation ceremony for that kid. That's what happened. That program became a 28-day program. Managed care company says, we're not paying for that. So social determinant of health, it changed, 28 days. This was a stellar program. It's not the same anymore. That's what's happened. I contend that the effectiveness of treatment is hugely impacted by your question about prior authorization. There's no doubt in my mind. 1, it creates an additional administrative expense for the provider. It really does. You pull your best clinical people offline to make sure the prior authorization process gets approved. You do. Best people pulled offline. Administrative costs to get those approved. They were suspended, and again, internally indebted to the cabinet for suspending prior authorizations during COVID and adding telehealth. Those 2 things kept the system. You're concerned about the system collapsing. Those 2 things kept it operational during COVID. Need to maintain those 2 things. But that's what happens. So you take time, and that time can delay access to treatment. Sure, I agree with my friends from the managed care company. Providers can enroll someone, right? But if that prior auth is not approved, yeah, it's 1 day of service, but it's still doing something you're not going to get paid for. So what lessons do we learn? We learn to ask for things that get approved. If someone's bordering day program versus residential, intensive outpatient program versus residential, we may go with the thing we can get approved. Okay? That changes the business practice. Is that in the best interest? The provider is going to be okay. And, my members aren't going to say that. But, it will work out. But the question is, what happens to the individual? And I'm going to tell you, one of the bravest things you can ever talk to someone about what they've done is make a decision to get treatment when they're addicted. It is a brave action by that person. They are admitting they cannot manage their own life. They need help. Make that decision. If that person is delayed an hour, 6 hours, or a day, they may go away, not come back. A person told me, who was through recovery, he thought about the first time he went off the high dive as a kid. That's what treatment was. He was afraid to do it. He didn't want to do it when people were standing around. He was afraid to go, but he finally did it. Treatment was the same way. And it didn't work the first time for him. He had to climb that ladder and walk out to the end of the dive and jump in and hope it'll be okay. But you delay access to treatment, only bad things happen to people. And maybe they come back 2 or 3 days later. Maybe they're okay. I don't know. But if you think about the 31,000 people I know about at mental health centers, and I suspect more than twice that in the other 600 providers, I can get 100,000 people. If 5% of those delay access to care, bad things will happen to those people. So it's a business problem. It really is. Increases our administrative expense. Things get denied. I can talk about your audits. It is a retrospective review. They come back and look at what you've done. And whether or not they take a penny from you, we are sending volumes of information to MCOs. Again, taking people offline. That is what it is. It is a retrospective review. We knew when prior auth was suspended, this was still a management tool that could be used. We're all going through that. Every provider's retrospective review. So it's costly, it's expensive. But in terms of the effectiveness, the biggest thing I have a concern about is the prior authorization process. I really do. I really think that delays access to care and bad things happen. Guy I know got into treatment. He is recovered. He is living the good life. He's a UK professor. But what would have happened if his family didn't have resources? His family was able to make sure it worked. If you're on Medicaid, you don't have resources. If you've been an addict for a long time, not all families are hanging with you. You can't delay treatment. So I would contend the business practice of prior authorization is a problem in substance use treatment. Is a problem. I think that's the key. It's administratively costly, burdensome. Sure, they can get access to people. We'll tell them who we have. I mean, that's not necessarily a real issue. But does that person delay? Does that person not make that brave decision? And then what happens to them? I think it's serious. And I think, overdose deaths are increasing. It's not decreasing. I remember there was a member of the General Assembly, Chairman Tilley, and he spent a lot of work on this issue, became a secretary of a cabinet, Justice Cabinet. And he said, we are chasing addiction, and meaning that people who are distributing drugs in our communities are going to be a step ahead of us. It's just how it's going to be. It was pill mills, then it was heroin, and now it's putting fentanyl and stuff. It's a bad, bad situation. We can't let anything delay it. I'm going to tell you what I've said many times to other groups. Behavioral health is a challenging behavior. It's a small piece of the Medicaid pie. Carve it out of managed care. At one point, we were about 3% of the Medicaid budget. You save 5% on 3%, it's pocket change, and you've killed the system. Medicaid expanded substance abuse, maybe we're 6, 7, 8% of Medicaid now. Is that enough to save enough money when these are folks? And the same thing, many of these folks also have mental illness. It's a big deal. So that's really what my message is. I just can't tell you how effective they are. I can tell you there's a lot of licensed providers. The ones I know are all doing good work. A lot of residential substance use providers, are they getting access to services? Are they being denied? I also think you all need to know there's a lot of stuff going on that's not Medicaid. Office of Drug Control Policy does great work. CORE, Kentucky Opiate Response Effort, federal dollars, does great work. Innovative stuff that's not Medicaid covered. They have a block grant to provide services to people. That's through the Department of Behavioral Health. Bridge clinics and ERs, Training, Narcan training. Don't say it again. It needs to happen. There's a group in Lexington who puts up Narcan booths in laundromats, kind of like the AEDs. Break the glass, get Narcan, because laundromats people hang out at night. I think it's a pretty cool thing. Recovery housing, recovering centers. Once you're sober, your life has changed. Your network of friends has changed. Talked to a young woman, the same situation. She knew no one after she was sober. Couldn't get a job because of her history. Walked dogs for a living, got a job third shift at a veterinary clinic. She's now living, have her kids back. But it was hard. Those are good service people are having. Need to do more of those. But the message is people can get well, they can recover, and they can move on with their lives. But anything that stops that process is a problem for me. I think it's just a drawback.
Well, Steve, the real tragedy is the federal government spending $35 billion on substance abuse recovery. And again, I don't know what kind of outcomes we're getting, and we're only reaching about 10% of the people.
I agree. I would love to discuss, what are the outcomes we want? One, it's not successful completion of programs, right? But what are the outcomes? People relapse. The outcome cannot be people will not relapse. I'm going to tell you they're going to relapse.
Well, I was hoping to get some of that today, but obviously that didn't occur, and maybe discussed for future. I'm sure it'll be a discussion for a future topic. But are there any questions for Steve? Representative Shelton.
Thank you, Steve. I just want to say that would it make sense to you? Obviously, I'm just trying to figure out some solutions. The MCOs seem to have left the building, so I'm not sure. We may have one or two left in here, and that's a shame because you're voicing some real concerns about things that need to change. Dr. Schuster did the same prior to this, so it's a shame that they're not around to listen to this. But anyway. What about, the PAs are so cumbersome, okay? So to me, it might need to be a balance between making them much more administratively cumbersome, okay? So that should not be that difficult of a project. You get some healthcare professionals in a room. We should be able to streamline that to some extent. Maybe
start services.
Exactly.
Do a PA a week later.
That's right. Yeah. And
it's just simple.
And was my next comment. It was, why wouldn't there be? We do that in hospital admissions, right? We immediately assume they're covered.
Yeah.
And we have so many days. I forgot how many days that is. I'm sure Senator
We're
Meredith
doing
will know.
that. A lot of centers do that, but it's still that fear. It's still the fear.
Yeah. Well, you're fearful that it may not get covered. So there should be some presumptive eligibility for a few days until the PAs had time to run. The delay would be gone. And then going back to a much more an easier process, and then and I just make this statement. For years I've been in around this business, and you get this comment. Why are people that aren't healthcare professionals? How come my provider's not making those choices? That's probably not a completely accurate fair. Yeah. So I think people need to understand that. There are some things in place to keep. Fraud and abuse and some issues. I get that. It needs to happen. But we've gone too much the other way. We've taken that pendulum and we swung it so far that now the providers literally are left in a situation where they're looking up on the insurance log what drugs they'll cover, and then they write for it. Or what diagnose or what procedure they can do, then they do it. So our whole healthcare system has been geared now towards what insurance companies have told them that that they can do, and so there needs to just be a really full understanding of when these decisions are made. This particular diagnostic procedure is covered, or this one's not. That came from a committee full of physicians that actually work in the trenches.
Yeah,
and I get the impression many times, certainly in the area of healthcare I'm in. I'm talking to people that have no idea, have never had their foot in the trenches. And that's if it's a misconception, I'm sorry, but that is how it's perceived. And that's how it feels when you're out there practicing, is when somebody's got to have it, and you're having to thumb through a book to figure out what you can do for them. So thank you very much for your
at some point, you have to stop doing it for free.
That's right. Exactly. Thank you so much.
Okay. In closing, I'm reading a book, and there's a quote in there where the guy says, I got about another 20 years left. That's enough time to work. It's not enough time to play. I don't have 20 years left. It's time to work and stop play with. So
I think we would agree. And got a question from Senator Alvarado. Question
Yes, sir.
or comment, possibly. Senator?
Thank you. And obviously I'm, everybody heard me vent earlier. Just so that people know, I think that it's not just me that's talking about this. Do you have a sense? The sense that I get is there's a clear disconnect from our MCO partners and what our medical providers are experiencing, because this has been something we've been clamoring about for 10 plus years now. And is that, maybe you can comment on that. Do you have that same perception that there's a disconnect from what our MCOs perceive as the real world in healthcare and what our providers are seeing as the real world? Because I can't otherwise explain one side saying we're doing a great job, everything's great, and providers not. Yeah.
We have monthly calls with 5 of the MCOs to discuss, and really the primary issue is payment. It's not clinical practices. One, I couldn't be on that call. I'm not a clinician. Dr. Schuster would be on that call. But we talk a lot about those things, and we do feel there's a disconnect between how we get paid and what we do. As an example, we have spent a decade discussing people who are dual eligible. They have Medicare and Medicaid. There's people that have both of those things. Kentucky Medicaid pays for what Sheila mentioned, targeted case management. Okay? Much needed service. Connect the resource in the community, kind of is the first person the individual goes to. Medicare doesn't pay that. We've been told repeatedly by managed care companies we need to have an EOB from Medicare to get paid for that. Medicare won't give you an EOB for a service they don't cover. There's no explanation of benefit because there's no benefit. Spent a decade on that issue. We think we got it resolved a decade later. We have licensed marriage and family therapists, master's level trained people. Medicare does not recognize them. Can you get an EOB? No. Medicare is not going to give you an explanation of benefit, whereas creditors, they don't cover. But we need to get a list from Medicaid to pay for that. We think we have that resolved. MCO came to the market. I told them before they came, this is the number one issue you need to address. It must be much more difficult than I understand, Dr. Alvarado.
Well, you have 20 more years. You can
Yeah, that's right.
Yeah.
Figure it out.
Okay.
Facetiously,
Yep.
again, why
Gentlemen.
does someone become a rocket scientist? Because they couldn't handle managed care claim payment. It's too hard.
Thank you.
Yep.
Quick question from Representative Elliott, then we need to move on.
Yeah.
We still have one more presentation we have to hear.
Yep.
Thank you, Mr. Shannon. You made the recommendation that this area of mental health treatment be carved out from managed care. Have any other states?
Some states have done that. Some
Okay,
states
so
have
it's been
carved
done
them
before.
back in, but they have carved it out for those benefits.
Okay.
So I'm not the first
So there's
person
an
to think of that.
example out there. Okay.
Yeah.
Thank you.
Thanks, sir.
Thank you.
Appreciate you
Bye-bye.
coming. Last but obviously not least, we have Commissioner Lee and Steve Bechtel to talk about the Medicaid budget. And again, folks, I appreciate your patience and indulgence as we've gone through this very long meeting. If you would, please proceed so we can move on here. Commissioner,
Hello,
are you on?
I am Senator Meredith. Can you hear me?
Yes.
Thank you so much. I'm Lisa Lee. I'm the Commissioner for the Kentucky Department for Medicaid Services. I appreciate all of the testimony here today. We all know that we have a long way to go to improving the health status of this state. We don't like being ranked 46th in the current America's Health Rankings. And again, we have a long way to go and we need to work together to get there. I know it's tempting to sit and talk about increasing provider rates and expanding services, but we have to have funding. And how can we do that? How can we do those two things without greatly increasing our general fund dollars? Maybe looking at more programs like we developed with KHA with HRIP. Maybe doing something like that. But talking about the Medicaid budget, I know that many of you have sat through the budget subcommittee last week when Steve and I did our presentation. So we have a very similar presentation with same information, but we're going to kind of go through it a little bit quickly in the interest of time. So Steve, can you please share the presentation?
So you can't see my screen?
Not yet, we cannot.
Hold on one second then. Can you see it now?
I think it's, there we go. If you can put it in presentation mode, that would be good. Or we can just go from there.
Yeah, we'll just go from there.
Yeah, just go to the
Not
second.
working.
Okay, go to the second slide, please.
All right.
So just a quick overview of our Medicaid program. From 2021, we had approximately 1.6 million individuals enrolled. That was their 2021 monthly average. Our current enrollment is 1.58 million, of which 3,885 are enrolled in presumptive eligibility. A little bit of a breakdown there on the individuals who are enrolled in our program. The third bullet that indicates 903 under a traditional non-ACA Approximately 500,000 of those are children. We also have over 59,000 enrolled providers. Their total budget in state fiscal year 2021 was 14.7. Next slide, please, Steve. And our eligibility experience, as you can see in March, we started seeing a huge increase. Of course, that was due to the COVID public health emergency. We do have a federal mandate that during the public health emergency, we cannot disenroll individuals from Medicaid unless they request to be enrolled, they are deceased, or they move out of the state. The reason for that maintenance of effort and us maintaining that eligibility enrollment was allowed us to receive that increased 6.2% FMAP from the federal government. And as you can see, we have experienced a little bit of a dip that's due to many individuals in the PE program disenrolling, but overall we have increased our eligibility by over 250,000 during the pandemic. And with that, I'll let Steve jump into his budget presentation. And again, I know many of you have seen this presentation, so we're going to kind of go through it rather quickly, but we will make ourselves available to answer any questions that you have after we skip through this rather quickly.
And just to make sure everybody, my name is Steve Bechtel. I'm the Chief Financial Officer for the Department of Medicaid Services. And I hope you can hear me and I hope you can see my screens. For some reason, the Zoom is acting up on me. So if you're seeing that table, if not, you can go to slide 5. Slide 5, just to give you a real quick overview of our budget, what we spent in 21 compared to what we spent in 20. We had a $2.5 billion increase in 21 over 20, which was about a 21.5% increase in expenditures. 91.4%, approximately 2.3 billion of that overall increase was in federal dollars. Now I understand those are still tax dollars, but those are federal funds that we're bringing into the state to help our providers out and to send out across our providers. 8.6% of the increase was in state funds. With 185 million increase, you'll see there on the restricted funds when you compare 21 to 20, we had a $185 million increase in restricted funds, and that's solely what's responsible for that increase was the HRIP program, where the hospitals pay an assessment, and we have those funds coming in to spend those as restricted funds for that program. And then we had a small increase in general funds. So like the Commissioner said, I'm just going to briefly go through really quick. But again, I've worked with many of you in the past, and I'm not talking for the Commissioner, but I know her heart, and I'm sure she'll agree that if there's ever a question, we're more than happy to sit with you guys and answer any questions that you may have. But you'll see on this, I'm going to go on over to slide number 7, which is a pie chart. It shows our total spend for 21, and it's broken down in between managed care and fee for service. You'll see 10.8 billion in managed care. Now, let me tell you what that is. That's the capitation payments that we pay to them, as well as supplemental payments and directed payments that we pay to providers through them. CMS requires us to pay those supplementals and those directed payments through the MCOs for the members in which they are responsible for. So, but at the bottom, you'll see that approximately 3.6 billion was in our total fee for service spend, and 10.8 billion was in the managed care. I believe that is what Dr. Alvarado was talking about earlier when he was mentioning 11 billion when he was talking with the MCOs. But you'll see that 10% of our population is served in the fee for service population, in the fee for service arena, which is about 25% of our spend. Obviously, that's the case because they're our most vulnerable and our sickest population is what we serve in our fee for service arena. You'll see that highlighted over there. I've kind of highlighted some key top categories of service. Nursing facilities is over $1 billion, as well as alternative community care. And alternative community care is all of our waivers together. They're all aggregated there. So you'll have a little over $1 billion there. So between our waivers and nursing facilities, they make up 2/3 of our fee-for-service spend. Now, when I say those other things, when you see those other items like hospital, pharmacy, dental, transportation, ICF, IDD, those are just the expenditures paid in the fee-for-service. All expenditures paid by the MCOs are included in their caps. So I just wanted to point that out. The last thing I want to point out on this slide is that negative $27 million for all other. That includes our drug rebates. Our drug rebates are a reduction of expenditures. And so that right there, that all other is all the other categories of services that we cover in our fee-for-service arena, minus the total overall drug rebate. And so therefore we had more drug rebate than what I had to mention here as the all other column. So I just want to mention, like Representative Sheldon, sorry, Representative Sheldon about that, but Representative Sheldon mentioned earlier that yes, we did have it was the largest year in drug rebates in 2021, state fiscal year 2021. Now, I'm not sure that was tied to the implementation of Senate Bill 50 because that didn't get implemented until 7/1, but it probably was related to the single PDL that started in January of 2021. So just wanted to make that comment. The next slide is we're going to go over why the $2.5 billion. What happened? Why did we spend more in 21 than versus 20? And you can see I've listed out several lines, but I'm just going to talk about the MCO line. I mentioned to you that there were several things that we paid through the MCOs. We had an increase of about $683 million for the House Bill 183 from 2021 session, which was the hospital rate improvement plan. That accounted for about 26% of the increased payment. Then you also had another 13% that was tied to the university directed payments. And what that is that's increased payments in 21 versus what we paid in 20. If you recall, as House Bill 183 changed those payments to a average commercial rate methodology where we were paying upper payment limits. So basically we would pay up to what Medicare would pay, but then we still heard from KHA and from the hospitals that they were still struggling financially. So we agreed to looking at exploring the average commercial rate to try to help them out on their financial situations. Because, we need providers. We have to have providers in order to serve our members. And we are a member-driven, member-focused organization. So I just wanted to touch base. The largest piece, 51%, is due to that increased enrollment that the commissioner was pointing out to you on slide 3, is a large piece of the increase amount on the managed care line is due to the increased enrollment, as well as some additional programmatic changes that were implemented in last year's session that we had to implement in the managed care session, managed care rates. The next is a per member per month chart. You can see here that it shows a increase in overall eligibility. We had about almost 18% increase in our enrollment. When you look at the average Medicaid enrollment monthly average in 21 compared to the monthly average in 20. On the PMPM though, well, let me talk about the eligibles. You can see the majority of that increase is on the expansion line. However, we mentioned about the presumptive eligibility. CMS required us to bucket those with those expansion populations due to the poverty levels in which they were in. So that's why they're there. But you can see that in contrast to the increase in eligibles, they had a decrease in their PMPM because we had a lot more people come in, but their utilization was lower. So you'll see that the overall increase of our PMPM from 20 to 21, we had about a 3% increase and what we paid in 20 per member per month. I'm not going to go over the admin slide, but I did hear earlier, I believe it was Senator Alvarado, that yes, when we have two appropriation units in our budget, we have a benefits and an admin. And what we spent in admin compared to our total budget was 1.5. Now, what that does not include is the admin that the MCOs are covering, like he said. That is because we cover that in a capitation payment. Those are paid under the benefits side of things. So I think I have a task from the BR subcommittee is to do a review of that, and I'm still working on that. So I will get back with you on that, Senator Alvarado. And then last slide that I think we're going to talk about is Commissioner, I'll turn it back over to you to go over the looking ahead slide.
Thanks, Steve. As we prepare to plan for the future in Medicaid, there are certain things that we definitely need to consider as far as our budget goes. Currently, we have some preprints. The pharmacy preprint relates to Senate Bill 50. Anytime we have a directed payment, that's something that we ask the MCOs, or we run through the MCOs and tell them or instruct them that they have to pay a certain amount to providers. We have to do a preprint. Those preprints are completed on an annual basis, and they have to contain quality measures. So again, each one of those will have to be done as we go forward. And I think that each year when we have to do those, we need to revisit the quality measures. Other things that may impact our budget that sometimes are unpredictable are any new federal or state mandates that impact our services. Many of you sit on the 1915C waiver redesign, so you know the need there. You know the waiting list for SCL and Michelle P. and some of the challenges we're facing in our 1915C waiver. Same thing for the SMI waiver, which is something that we have not completed, have not submitted, but there is talk of creating an SMI waiver. Assisted living facilities, we have been asked to look into covering assisted living facilities. Again, that would be another budget impact. We currently have a pending SUD for incarcerated waiver at CMS. This is an 1115 waiver that would allow Medicaid to pay for certain services for individuals who are incarcerated and assist them with their return to the community, and hopefully increase their chances of being successful and reduce recidivism. We also have some information technology costs. For example, we have an electronic visit verification software or program that is mandated by CMS. So we have to do this electronic visit verification. This is mainly for individuals who are in their home. They are currently in 1915C waiver programs. This electronic visit verification allows us to monitor and track providers who go into the home and make sure that the amount of time being spent in there is actually what's being reported. That will have to be expanded to home health agencies in the future. We did request funding for that in our previous budget, but it was denied. So therefore, this is an unfunded mandate. We do know that we want to focus on health outcomes. Senator Alvarado, I agree with you that we need to start focusing on what's killing us: asthma, diabetes, heart disease. We really need to figure out how we can focus on those health diseases, or those diseases. Make sure that we can do some not quality measures, but just some interventions. What do we want to look at? What do we want to improve? Is it different in Eastern Kentucky than it is in Western Kentucky? What can we do to really start moving that healthcare needle? And I think there are some things that we can do that we can maybe see more improvement sooner. For example, Kentucky ranks 37th in low birth weight. Maybe we could do some maternal and child health measures. I know that we could, in April, for example, we could expand postpartum care for women to a year rather than 60 days. I know that that's something that has been talked about in these committees. And again, we currently rank 46th overall, according to America's Health Rankings in 2020. So we definitely need to start moving that healthcare needle. And as we can see from the testimony today, we do have a long way to go in improving the health status of this state. But I think if we start thinking outside the box and we start identifying specific health outcomes that we want to start seeing, I think we can get there. It's going to take a while, but definitely want to start moving that healthcare needle. Steve, you can stop sharing your screen, and we would be happy to take any questions you may have.
Thank you, Commissioner. Thank you, Steve. Appreciate your presentation as always. Let me ask a couple of brief ones. The proposed $14.9 billion, does that reflect the decrease in the federal match that we're going to see in I think it's 2023, in 0.58%?
Are you talking about, I'm muted, yes.
No, yeah.
Yeah, I'm just making sure. I muted myself a while ago. Did you say the FMAP that we're decreasing in 2023 that just came out yesterday?
Yes.
No, because that is state fiscal year 2022.
Okay.
So the 2022, though, it did include the 6.2% increased FMAP as a result of the PHE through December of this year.
Do you know how much that 0.58 will cost us?
The 6. Oh, no, I do not.
Okay.
The 5 point. We are in the process. I met with the state budget director's office yesterday. Like I told you, we were working on our consensus forecasting. We're still going to meet again tomorrow. So that's we're still in the process of doing that analysis.
The $14.4 billion we spent this last year. Mm-hmm. Can you identify what percentage that may have been specific to COVID-related illnesses?
We don't have those numbers specifically right now, but I can get those to you. We do track COVID-related costs and the number of individuals who are diagnosed with COVID. I can get that information to you rather quickly. I do have it in another presentation and can email that to you, or can look for it right now while we're sitting here. But I think that can get it to you rather quickly.
Okay. Well, obviously, I think we need to have some inkling what that is in terms of what we do this next fiscal year. But kind of a loosely related question that I know that our population in Kentucky, we're now about 60% vaccinated. Do you know what that is specific to our Medicaid population? What kind of job our managed care partners have done?
Yes, we have in our managed care and our fee-for-service population, we're upwards of well over 70% of our fee-for-service. That's individuals in long-term care facilities and individuals in our waiver populations. Our MCO vaccination rates are right around 35% right now. So we do have a long way to go in our MCO vaccination rates.
Just 35%.
Overall, and that is for individuals 12 and over. If we break it out by age cohorts, the elderly population or the older population are more vaccinated than the younger.
All right, thank you. Question from Senator Alvarado.
Thank you, Mr. Chairman. A couple of quick questions, guys. On the you mentioned earlier on, I don't know why I thought of it, maybe because I got an email and I think I may have forwarded to you, Commissioner, on eligibility. If someone is signed up for Medicaid during COVID, let's say they had lost their employment, signed up, got Medicaid, and then I have a constituent who said that they went ahead and got a job, but I don't think notified or didn't know to notify, had never been on Medicaid, that he had gotten a job and continued to receive, was still on Medicaid. Someone was paying the Medicaid bill to the MCOs. Based on what you made a comment earlier that once you were on, you couldn't take people off. Would that apply to somebody like that as well?
Well, it would depend on his specific eligibility category. If it is presumptive eligibility, that is not included in the maintenance of effort. But we do have a maintenance of effort. If anyone is enrolled in the Medicaid program, in the traditional Medicaid, not presumptive eligibility, based on CMS guidelines, we cannot disenroll them unless they ask to be enrolled, they move, or they are deceased. So if that individual calls and asks to be disenrolled, we can disenroll him. If in the event that they have other health insurance, we would be a payer of last resort. So if he retained a job that offered health insurance, we would be payer of last resort. And we have to maintain that MOE to get that 6.2% FMAP.
Gotcha. I was curious because when you mentioned that, I thought, well, I got a guy who's going through that right now. He was working, lost his job, had to go on Medicaid, and then went through a divorce, some other things, and then wound up getting another job, but never went back and notified because he didn't know to. He just assumed that it would be dropped off. Now he's being told you owe all this past premium, and so he's worried. It's a constituent issue. Second question I've got: I know the governor keeps talking about $1 billion that have been paid to hospitals. And many of you may have heard my testimony about trying to get funding for our hospitals for nursing and that sort of. We're making some efforts towards that. He talked about $1 billion that have been paid to the hospitals. My understanding is that was the ATRIP money that came through. That was what the hospitals had paid in to draw down more federal funds. Is that what he's referring to when he talks about those funds? Do you guys know?
I would have to go back and look at the specific comments that he was making, but about $1 billion is the Hospital Reimbursement Improvement Program, where they pay the assessment and then they draw down the federal dollars. So there's the additional federal dollars are coming in.
Yeah, and that was my understanding, was that money was what the hospitals put in, only to get that back just to get the federal. Right. So that's the third thing. Also, I'm talking about healthcare metrics from the MCOs. I was pretty critical. If they're coming to us with a testimony today saying, "Here's what we've done with this many years of it," do we have anything in their contracts to hold them accountable? Because we're turfing all this care to them. To say, are they doing anything to help us reduce diabetes, cancer, hypertension, 9%, I'll take that reduction, it's better than zero, but heart disease, all the things that are killing us, is there anything in those contracts holding them accountable that if they don't hit certain metrics, they get dinged on that as well? Or are we just saying, we want to see you do this, and then they're going to go after providers? I'm just curious if we have any teeth in those contracts.
I'd have to go back and double check, Senator Alvarado, but I don't think that we have enough teeth in those contracts. And as you know, the current contracts are under appeal. We need to rebid those. And I think that this provides an opportunity for us to actually put some teeth in those contracts. I myself would like to see some very concrete penalties related to exactly what you're talking about, how we should set some measurable goals that we think that the MCOs can meet over a certain period of time. For example, increase the number of individuals who adhere to their asthma medications or diabetes medications. I mean, and those things, I think we're going to need to have input from, I think, all of our cabinet medical directors. I think the Medicaid Oversight and Advisory Committee is a great place to start making those recommendations about the types of things that we would like to see in the contracts going forward.
I totally agree with that. And I think you're probably going to get a lot of support from our members of our committee that, they've had 10, 12 years. But the only thing that seems to motivate these guys, and I've been very critical of it, maybe because I just come from a different angle of what I do, but they haven't done that on themselves. They're only going to do what they're obligated to do. Nothing is being done out of, hey, this is kind of understood. So if we have to do that, I think we got to start putting those in there. And then the last thing, you guys do a great job, Commissioner. I've been pleased. You, Mr. Bechtel, you guys have done a great job for us, with very receptive to all the issues I've ever had on issues of Medicaid. And you've heard Senator Meredith and I talk about this, maybe looking at a different model of delivery for Medicaid. And that's always, everybody bristles because it's just a huge sea change. Do you think that, I remember the days when the government controlled, a lot of the payments and all that. People complained back then, but people are almost longing for those days again, because it was a quicker response time. There was some reasonableness to how things were approached, I think is the best way I could put it. Do you think there's any opportunity for, as far as changing that, do you think we could do a better job of managing? We've done that kind of with the PBMs. We brought that back in. That was from the legislature. But having seen the success and how you guys have the initial rollout of that, I know we're still going through some growing pains on how that's being managed. Do you think we could do the same thing when it comes to the managing of Medicaid care? Could we do a better job? I know they provide a lot of data collection, maybe a different kind of emerged method of doing that. Your thoughts as to, could we do better if we brought a lot more of that back in or changed our model?
Well, I think that the healthcare, particularly Medicaid, is one of the most complex programs around. I do think that the MCOs bring value in that they can do pilot programs. They can actually think outside the box. When Medicaid manages the program, anytime we want to change a benefit, anytime we want to change provider payments, we have to get approval from CMS and go through that lengthy process. And then when we talk about the administrative costs, the MCOs get 10%. As our chief financial officer testified, Medicaid's currently almost at 2%. We just don't have the bandwidth, I think, in the department and to be able to do some of the things the MCOs do, given our small administrative costs and the skill sets of some of our individuals. You know, we moved to Medicaid managed care in 2010, and we had to we had to pivot the Medicaid program and be more of an oversight agency rather than just paying claims. And so some of our training has not caught up to that oversight committee. So it would definitely require a big investment in the Medicaid program and the administrative, especially in administrative.
Thank you. We're brainstorming, Senator Meredith, on our, and IR on different things we can do, but and maybe still continue with that oversight model. I'll leave it at that. It'll be a 2-hour conversation on the topic, but I appreciate your insight and thank you all for the job you're doing.
So if I may just say one thing, there is on the ATRIP program, if we did bring it back in house, we would not be able to do the average commercial rate because that's only when it comes through the fee for service, I'm tied to the upper payment limit of Medicare. So that would be a decrease for the hospitals there on that supplemental payment.
Thank you.
Well, to Senator Alvaro's comments, I think the payment mechanism for the MCOs could be vastly improved. And if they're truly improving the health of our population, there should be significant savings from that. And if they're capped at 10% of what the Medicaid funds are, I don't think that's a sufficient incentive to think outside the box. So to that end, I would like to see us be really aggressive. If you truly improve the health of the population, then I think as part of a symbiotic relationship, they should share in that. And I think we need to look outside that box because right now we're limited. I mean, quite truthfully, if I'm in their business, if you say I got to spend 90 cents on the dollar, I'll spend 90 cents on the dollar, and the 10% is going to be my profit margin. Again, that doesn't incentivize them to improve the health of the population. Matter of fact, it's kind of a disincentive. So I think we need to take a hard look at that as well, but that's another conversation for another day. I know this has been a very long meeting. My apologies for that, but appreciate everybody's attendance and participation. With that, our next meeting is October 26th at 1 p.m. If there's no further business, motion to adjourn.
So moved.
Second. Adjourned.